Um, Hi guys, waiting to make sure that the stream is live. So, as you all know, today we are going to be doing nerves of the upper limb, right? So, nerves of the upper limb, as you all know, is a topic that is that will be part of your professional examinations also, and the first mid semester examinations if you are watching this video for that, and as well as for your entrance examinations. Okay, so let's begin with the topic in a minute. Before that, uh, if anybody can hear me, please write a yes in the chat so that I know that you all can hear me. Right. So, okay. I can hear myself on the stream on my phone. I'll just begin the class. So, topic for today, like I told you, is nerves of the upper limb. Nerves of the upper limb. And it's a very good summarization. So, I had taken a class called the arteries of the upper limb on Unacademy's platform, right? So you can log on to my Unacademy page and you will find this class where I had summarized all the arteries of the upper limb, starting right from the axillary here. It even told that it begins from the subclavian, axillary, brachial, radial, ulnar. We covered everything. Alright. So today we are going to be doing nerves of the upper limb, and this lecture is divided into four parts, right? Brachial plexus, radial nerve, median nerve, and ulnar nerve. So we'll be doing the three major nerves of the upper limb, and we'll be doing the brachial plexus. So these are the four topics that we will cover, and with each of these topics we will also have MCQs, right? So welcome to Let's Crack NEET PG, the YouTube channel of Unacademy, India's largest online learning platform, their NEET PG division, where you have the top educators, quality content, and you will have a great learning experience. So first of all, who am I? Right, so what would you do? No, my exams have still been postponed till December, so my exams are not over. So my name is Chetanya Mittal. I am a third semester MBBS student at All India Institute of Medical Sciences, New Delhi. All India rank 4 in the AIMS examination UG, and All India rank 5 in the JIPMER UG examination, right? And the advantage of learning from me is that I have just gone through all of these concepts and I am fresh with them. So we're both learning from each other here. And if there's anything that you wish to ask, you're always welcome to do that on our Telegram channel, that is at the rate NEET PG Chetanya, where we also have a discussion group for any of your doubts. Okay, so you can join this. And besides that, that is more or less about me. If there's anything else you wish to know, you can always ask. Let's move on to, so yeah, like I said, today's flow. First we are going to be doing the brachial plexus, then we'll be doing some 7-8 MCQs on the brachial plexus, right? Then we'll be doing radial nerve, then MCQs, then we'll be doing median nerve, then again MCQs, finally we'll be doing the ulnar nerve. So today's lecture is a long lecture, right? Today's lecture is a slightly long lecture, but if you pay attention, if you pay concentration, you'll be done with a huge part of the upper limb, right? Because the understanding of the nerves, the understanding of the nerve supply is very important when you come to anatomy. That is the main thing that you have to learn from anatomy. Even more important than the arterial supply is always the nerve supply, because nerve supply damages, you should know which area, which muscles, which sensory loss will occur. So that is why nerve supply as a topic by itself is very important. Before I begin, it is my job to tell you about the Unacademy's Plus subscription. So as you can see here, all of these are Plus courses on Unacademy, and you can see that all of these courses are locked, so you will get access to them once you purchase the Plus subscription. Besides that, there are a few special classes on Unacademy. Special classes basically means that these classes are free of cost. These classes are absolutely free of cost. Since they are free of cost, they are called special classes, and you can access them on the Unacademy platform. Even this is a special class since you're getting it free of cost, and the best part is you're getting this on YouTube. So you don't have to download anything. So, so basically, my suggestion to you would be, even if you don't plan on taking a Plus subscription, please still do download the Unacademy Learning app, because even if you don't buy the subscription, you can still access all this free content. You can also give these free mock tests, and if you have a Plus subscription, you will have ample practice, ample number of questions to attempt, no matter what. So why you should be learning online, why you should be learning in such a system is, first of all, in the lockdown, as you know, offline coaching is kind of nobody's going, they're not operating well, right? So Unacademy is India's largest online learning platform, and the good part about here in the PGA thing is that since we're all very busy, we have very busy schedules, so flexibility is very important for us, okay? And since we all study in different parts, we have different languages, English, Hindi, किसी में भी सीख सकते हो, you don't have to stick to what the teacher is teaching you. You will have educators who are teaching in English, और ऐसे भी लोग होंगे जो हिंदी में पढ़ा रहे होंगे, मैं दोनों में पढ़ा सकता हूँ, ठीक है? और अनलिमिटेड प्रैक्टिस ले लो यहाँ पे। उसके अलावा सिंस आई हैव ओपन द चैट बॉक्स हियर ऑन माय फोन, सो आई कैन रीड वट एवर यू आर सेइंग, एंड सो इट विल फील लाइक यू राइट हियर विद मी, so you can basically chat with me, and I'll try to keep the MCQs interactive. I'll ask you those questions, and you can basically be learning from anywhere. So just download the Unacademy learning app, and after that, if you want to take a plus subscription, so these are all the plans. I'll come to the plans later, but what is important here is you have to enter a referral code here, and there is only one referral code that you should be entering, that is Chetanya 10. Now, why you should be entering this referral code is, first is the basic reason that you will get a straight 10% off. ये 40,000 है, ये साथ के साथ ही 36,000 बन जाएगा, right? So you will get a 10% off direct. And besides that, if you contact me, I will tell you how to use these credits, where you can get an additional 10% off. And besides that, I will give you some cash back from my end. So somebody had taken a plus subscription for 1 year, and out of the iconic subscription actually, and I had given them a 4,000 cash back from my own side. So you can contact me at my discussion group, or you can contact me on Instagram at @Chetanya.blue. And this is not just for NEET PG subscriptions, any kind of subscription. If your brothers, your sister, your parents, anybody is taking a plus subscription, you can contact me and I will give you the best deal, right? So that is how you apply the referral code. You click on apply. All right, so you can see that this directly became discounted. Now talking to you about the plans for NEET PG. So these are the plans for Unacademy Plus, and these are the plans for Unacademy Iconic. Now what is the Iconic subscription? The Iconic subscription is basically, as you already know, that Unacademy is India's largest online learning platform. But for medical preparation, PrepLadder is a very leading platform that has been recently acquired by Unacademy. So Iconic subscription, you not only get Unacademy Plus, but they're also giving you PrepLadder, where you have, again, you have PrepLadder ka question bank, you have their videos, right? So you get full access, to everything. And I would really recommend that you take this subscription. If you're in the second year or at the end of the first year, you can take this 3-year plan. If you're already in the second year, take the 2-year plan, or if you want to take the 1-year or the 1.5-year plans, you can take these. And again, you can use my referral code. You'll get a 10% off, and I'll tell you how to use the credits, and I'll give you some cash back. So this will, if you're able to use the credits, this will come down to somewhere around 70,000 for you, and that is a pretty good deal for 3 years, since offline coaching जब होती थी UG की 1 साल की, so that used to be somewhere around 1 lakh itself. So 3 years, 70,000, decent amount. And yeah, so this is the plan I would recommend, because again, PrepLadder का advantage काफी होगा. PrepLadder by itself costs 50,000 if you take it for 3 years, right? So let's start with today's class. Today's class is about the brachial plexus. First of all, so what we are going to be doing is we'll break this into 2 parts. First, we will do the theoretical part of brachial plexus, and then we will do the clinical anatomy of brachial plexus, right? In clinical anatomy, we'll talk about Erb's and Klumpke's paralysis, right? And here we will do MCQs separately of both these topics, ठीक है? So comprehensive coverage रखेंगे brachial plexus की and its clinical anatomy. So let's start, guys. First of all, while understanding the brachial plexus, it is important to know that it is divided into, you divide the parts of the brachial plexus starting from superiorly to inferiorly, based on what is exactly there, right? So you will have roots. So those are the ventral roots of the various spinal cords, ठीक है, जो भी spinal nerve आ रही है वहां से. These roots, they will join in different ways. They will join in different ways to form trunks. These trunks, then all of these trunks divides into an anterior and posterior division, right? So anterior and posterior divisions of each, and then finally you will have cords which are formed by merger of these divisions. Then these cords will further give you some branches. Then there are a few branches that come directly from the roots, or they can come directly from the trunk. Okay, so there are a few points to note here. first of all, let's have a conceptual understanding of what all of this is, and then we'll move there. So like I said, there are few roots, right? So first of all, you should know the root value of the brachial plexus. Very basic, very important. C5 to T1, right? So C5 to T1 will mean C5, C6, C7, C8. Sometimes there can be a contribution from C4, that is known as a prefixed brachial plexus. Alright, prefixed means पहले से ऊपर से contribution आ रहा है, उस केस में T1 का contribution कम हो जाता है. Or it can be a post fixed brachial plexus, that is there is a contribution from T2. Alright, but चलो, we will not go into the prefixed and post fixed brachial plexus की details. So ये आ गई roots C5, C6, C7, C8. अब क्या होता है, C5 और C6 की roots, they combine to form the next thing, that is the, after roots you had trunks, after roots you had trunk. So C5, C6 roots, they will combine to form the upper trunk. C7 root continues as it is to form the middle trunk, and C8, T1, they will combine to form the lower trunk. Simple enough, right? So after roots, after trunks, here then you will have divisions. Here you will have divisions. So the upper trunk, it will divide into an anterior division and a, so basically ventral dorsal लिख देते हैं इसको, because कैसे भी लिख लो, it doesn't matter actually, but I will prefer writing ventral dorsal here. So ventral dorsal, middle will divide into ventral and dorsal, and lower will divide into ventral and dorsal. Now remember the dorsal of all of these, the dorsal root of all of these, it merges to form, so after divisions you will have chords, after division you will have chords, right? So remember the dorsal division of the upper of all the trunks, the upper, middle, lower, all the dorsal divisions, they will combine and they will form the posterior chord, they will combine and they will form the posterior chord, right? And then there will be a crossing here, and these two will merge, and this will continue as a chord in itself. So you can see here that these two divisions, the lateral chord, it is formed by the lateral chord, it is being formed by the ventral division of the upper and the middle trunks, and then the medial chord, it is basically a continuation here of the ventral division of the lower trunk, right? So that is how schematically the brachial plexus will move on into these chords. Now these chords, they are with respect to an artery, and I have told you that with respect to which artery they are present in the lecture on arteries of upper limb. So if somebody can tell me in the chat why this is called as the lateral cord, why this is called as the posterior chord, and why this is called as the medial chord. All of these are in relation to which particular artery. All these chords, they are in relation to a particular artery. What is the name of that artery? Can you tell me in the chat? Can you tell me in the chat? There is an artery with which they are all related. What is the name of that particular artery? Alright. If you're not able to guess it, you can watch the lecture on arteries of upper limb. Okay. I'll just tell you, I'll give you a hint. It is not the brachial artery. Yes, right. Shraddha Sharma is absolutely right. It is the axillary artery, right? So all these chords, so if this is your axillary artery, if this is your, let's say this is your axillary artery. Now if I take a pen and I show you, let's say this is the orientation here. This is the medial side, this is the lateral side, right? Let's say this is the medial side, this is the lateral side, this is the anterior side, and this is the posterior side. Let's say, for example. So the medial chord, it is present here. This will be automatically the medial chord, this will be the lateral chord, and this will be the posterior chord. So it is in this triangular arrangement that they are running. This is a triangular arrangement in which they are running around the axillary artery, and that is how they derive their names. That is the lateral chord, the posterior chord, and the medial chord. So after chords, what do you have? After chords, you will have certain branches. Now all these branches, it's a little difficult to remember, so that is why we have mnemonics for all of these branches. But before we go to the branches that are coming from the chords, first let's talk about the branches that are coming directly from the roots of the brachial plexus or from the trunk of the brachial plexus. So I've numbered those particular ones. I've numbered those branches which are coming directly. So first tell me which are the two branches you can see. So I'll tell you first one thing, that there are two branches that come directly from the roots, and then there are two branches that come directly from the trunks. There are two branches that come directly from the roots. There are two branches that come directly from the trunks. उसमें भी सिर्फ upper trunk से आते हैं. Alright. So there are two branches, two direct branches from the roots of the brachial plexus and two direct branches from the trunks of the brachial plexus. अच्छा, एक और बात याद रखना यहाँ तक. So somewhere here you will have the clavicle. So this roots and trunks, they are supraclavicular parts. They are supraclavicular parts of the brachial plexus, right? And below that you will have infraclavicular parts of the brachial plexus. Alright. So directly, the branches that are coming directly from the roots, what are those? You can see that there is this branch that is going here. This is the dorsal scapular nerve. This is the dorsal scapular nerve. First branch coming directly from the roots, right? So which root is it coming from? It is coming from C5. It is coming from C5. And then you can see here that C5, C6 and C7, they are contributing to form a nerve here known as the long thoracic nerve. And the long thoracic nerve will supply the serratus anterior. It will supply the serratus anterior, right? So you have to be aware that the long thoracic nerve and the dorsal scapular nerve, they are the two nerves that are coming directly from the roots. We'll talk more about them in a further slight detail. Look here now. What are the branches that are coming directly from the trunks? Okay, what are the branches that are coming here directly from the trunks? So this is basically the upper trunk. This is basically the upper trunk. And from the upper trunk, you can see that you have this nerve coming. This is the nerve to subclavius. So you can see it is coming together from the C5 and C6 together. Hai na? So nerve to subclavius, it is being formed here where you have the trunks. So nerve to subclavius, it is coming directly from the upper trunk. Very important to remember that nerve to subclavius is coming directly from the upper trunk. And suprascapular nerve is another nerve that is coming directly here from the upper trunk. Suprascapular nerve. So two nerves. Okay. So now tell me, let's just summarize this again. Two nerves coming directly from roots of the brachial plexus and upper trunk of the brachial plexus, right? Upper trunk say you will have first nerve to subclavius. Second, you will have the suprascapular nerve. Here you will have the dorsal scapular nerve. And second, you will have the long thoracic nerve. 1, 2, 1. Alright. Next, let's move on to what are the branches from the roots. Here we talked about the dorsal scapular and we talked about the long thoracic. Now, long thoracic, I already told you that it supplies the serratus anterior muscle. It supplies the serratus anterior muscle. एक मिनट यार मैं AC ऑन कर लेता हूँ गर्मी में थोड़ा सा. Yes. So like I was saying, branches coming directly from the roots, we already talked that there are two branches. One is the dorsal scapular, second is the long thoracic. So this is the anterior view of the scapula. This is the anterior view of the scapula, and this is the posterior view of the scapula. Alright. You can see all the muscle attachments here. So I will tell you two things. One, the long thoracic nerve. So long thoracic nerve will basically be supplying the serratus anterior muscle. And serratus anterior muscle, it is having this attachment on the anterior surface of the scapula. Some slight attachment on the margin. ठीक है, तो दे ये serratus anterior वाला clear है. What about dorsal scapular? What are the muscles that are being supplied by dorsal scapular? So remember, dorsal scapular will supply the retractors of the scapula. It will supply the retractors of the scapula. So now what are these retractors here? So again you will go on the border. First, from the top, coming from the top of the neck, you have the levator scapulae muscle. First, you will have the levator scapulae muscle. Yes, Amreen Sheikh has written the correct answer here. First, you will have here the levator scapulae muscle that is being supplied. Second, you will have the two rhomboids. They are also retractors of the scapula. They are present along the border. If you see it from the posterior view, here you will have the rhomboid minor, and then you will have the rhomboid major. So essentially, if I am to make a schematic diagram here, you can see here that if this is your scapula, and let's say I've drawn this as the acromion process, the spine, right? So here you have a muscle that is called as levator scapulae, right? Then here near the spine you will have the rhomboid minor, and then here you will have the rhomboid major. So these three muscles will be supplied by the dorsal scapular nerve, right? So you have to remember branches from the roots first of all. Second comes branches from the upper trunk. Two branches coming from the upper trunk. One was the nerve to subclavius. So it's obvious that since it is the nerve to subclavius, which muscle will it supply? Subclavius muscle, right? Which is again attached to your clavicle, or just inferior to the clavicle. In fact, it takes its origin from the clavicle, right? So nerve to subclavius. Supplying subclavius muscle. Sometimes the nerve to subclavius will give off a branch known as the accessory phrenic nerve. Alright, so you know there is a phrenic nerve, and which mainly comes from the C4, and you have an accessory phrenic nerve which can be coming from the nerve to subclavius, which will supply the diaphragm again. Sometimes the nerve to subclavius gives another branch known as the accessory phrenic nerve. That's just a point that you should remember. If it is asked that accessory phrenic nerve is a branch of, the answer will be nerve to subclavius. Okay, so that was nerve to subclavius. Now suprascapular nerve. I hope you know the relation of suprascapular nerve and suprascapular artery. Okay, there is a ligament. One nerve passes below, artery passes above. Alright, suprascapular nerve and suprascapular artery, there is some relation between these two. That relation is important. So what is the nerve supply here? The suprascapular nerve, you can see that it will be supplying two important muscles here. One is the, so you can see this back here, you know the dorsal scapular was supplying this. So now what are these two muscles? This is the above the spine of the scapula, so this is the supraspinatus, and this is below the spine of the scapula, so this is the infraspinatus muscle. So these two muscles, the supraspinatus and the infraspinatus, both will be supplied by the suprascapular nerve. Okay, please don't think that it is the suprascapular nerve, so it will supply only the supraspinatus. It supplies both the supraspinatus and the infraspinatus. So now if I come back to this schematic diagram, here you had the above the spine of the scapula you have supraspinatus, below the spine of the scapula you have infraspinatus. So supraspinatus and infraspinatus, they are both being supplied by the suprascapular. So I hope this is crystal clear that what nerve is being supplied by. So now if you know that abduction of the upper limb, you have some angles. The initiation of the abduction, means that if this is 0 degree, this is 15 degree, this is 90 degree, and then this is overhead abduction. All right. So the initial 15 degrees, that is the initiation of the abduction, is done by supraspinatus. After that, the deltoid takes over till 90 degree, and after that you need the trapezius. After that you need the trapezius. So supraspinatus, deltoid, trapezius. All right. You will also use serratus and latissimus a little bit, but mainly trapezius. All right. So if I damage the suprascapular nerve, can you tell me, will the patient be able to abduct his arm by himself? No, right? Because the supraspinatus, it was having a role in the initiation of this abduction. So this initiation of abduction will not be possible. So what does the patient do? The patient will use gravity. He will do this so that this initial abduction, it occurs due to gravity. He will bend forward, so the arm automatically moves away from the body, and then the deltoids will take over and he will be able to raise his arm. So it can be asked sometimes in a viva that how does a patient who has damage to supraspinatus, how does he use gravity to use for the initial abduction, for the initial 15 degrees of abduction, because he cannot do it by himself. Can you imagine this bending, and due to that this initial abduction happening, and after that the deltoids taking over? All right. So now let's move to the branches from the chords, if you are clear from the direct branches. So the branches from the chords. So there are three here. One is the lateral chord, then you have the posterior chord, then you have the medial chord. So you have three chords. Now we have to talk about what will be the various branches here. So remember these mnemonics first of all. So simple, for lateral chord the mnemonic is LML. Alright, LML. So in my mind there is this thing that there used to be a lemon juice called LMN. So I just make it LML here, right? LML. Very easy to remember for lateral, because lateral begins with L, and then you can easily relate that it is LML. Okay. For medial, it is M for U. M for U. Right? So M for U. Here means 4 means that there are 4 structures which begin with M. So this is basically M, 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 U. Alright, M4. Remember this second mnemonic for branches from the medial chord. Then branches from the posterior chord, you can either remember lunar or you can use ulnar. So I used to use ulnar, but then some of my batchmates, they were getting confused that the ulnar nerve is a branch of the posterior chord. No, the mnemonic is ulnar, but the ulnar nerve is a branch of the medial chord, not of the posterior chord. So another mnemonic that you can use instead of ulnar is lunar. Alright, you can use any of these two. I will still go with ulnar. Alright, because it is easy for me to remember that ulnar is the mnemonic for the posterior chord, but the ulnar nerve is actually a branch of the medial chord. We'll just come to that. Alright. So let's talk first about the lateral chord. So what was the mnemonic for the lateral chord? LML. Right? LML. So let's just change the ink color to black. So L here, the first L, it stands for the lateral root of the median nerve. So what are the three major nerves? The radial nerve, the median nerve, and the ulnar nerve. So ulnar nerve, as you know, comes from the medial chord. The radial nerve, as you know, comes from the posterior chord. So the medial nerve, it is contributed by both the lateral chord and by the medial chord. Alright. So the lateral chord gives the lateral root of the median nerve, and the median nerve here will give the medial root of the median nerve, right? So this is one is very easy to remember for both the lateral chord and the median chord and the medial chord. Sorry, what am I saying? I'm getting confused with the medial nerve. This is the median nerve, this is the medial chord, and they will give the medial root. Alright. Again, let's do this. Lateral root of median nerve is the first branch coming from the lateral chord, that is here for L. Then second, after L you have M. M is musculocular cutaneous nerve. And musculocutaneous nerve, I will show you later. It continues as the lateral cutaneous nerve of the forearm. I will show you the course of the musculocutaneous nerve after we are done with the brachial plexus. Okay, so don't worry. I will tell you about the nerve supply also of the musculocutaneous nerve. It is relatively important. Then final L here is lateral pectoral nerve. Final L here is lateral pectoral nerve, and it pierces two important structures. First structure that it pierces that you should remember is the clavipectoral fascia. So you should remember the structures piercing the clavipectoral fascia. Structures piercing the clavipectoral fascia. There are four. You know the mnemonic CLAT. L. Sorry, not CLAT. Here the mnemonic, there is a mnemonic here for the structures piercing the clavipectoral fascia, and you should be knowing that. So then here in that mnemonic, L is basically lateral pectoral nerve. We're not going into the details. C is cephalic vein, then you have lymphatics there also. So L you have to remember is lateral pectoral nerve. Okay. The first structure that is being pierced is the clavipectoral fascia. Second structure that will be pierced will be the pectoralis major. Second structure that you will pierce will be the pectoralis major. So I hope you will be able to remember L, M, L. So remember in the this is the lateral cord, and for that you should very easy to remember. So I'll just correlate this with the medial cord once we are done with the branches of the medial cord. Lateral cord, lateral root of median nerve, musculocutaneous nerve, and lateral pectoral nerve, which pierces two structures, clavipectoral fascia and pectoralis major. Since it pierces the pectoralis major, it will obviously supply the pectoralis major, but it does not supply the pectoralis minor. Again, very important to remember that the lateral pectoral nerve, it only supplies the pectoralis major. Right? Am I right? Can you write a yes or no? See, let's go here with the mnemonic. The mnemonic is CLTL. Alright, for structures piercing the clavipectoral fascia. Structures piercing clavipectoral fascia. Right? So C here is cephalic vein. C here is cephalic vein. L here is lateral pectoral nerve. Lateral pectoral nerve. T is thoracoacromial artery. T is thoracoacromial artery. And L is lymphatics. L is lymphatics. So you can remember this as CLTL. Alright. So this is about the lateral cord. Now let's move on to the posterior cord. So posterior cord, I told you that the mnemonic that I am going with is ulnar, ulnar, right? But remember that the ulnar nerve is not a branch of the posterior cord, but it is a branch of the medial cord. Okay, ulnar में U and L are very easy to remember. Upper subscapular nerve, lower subscapular nerve. U is upper subscapular nerve, L is lower subscapular nerve. Alright, very easy to remember. Then R is also very easy to remember. You know that the radial nerve, it is a continuation of the posterior cord. Now N and A are left. Alright, A is axillary nerve and N stands for nerve to the latissimus dorsi, which is also known as the thoracodorsal nerve, which is also known as the thoracodorsal nerve. Right? Easy enough? There's another mnemonic that people use for this. Alright, I will tell you that also, which is a little more different to remember. Alright, so if you can remember both mnemonics, it will be a little more easy. So what is the first mnemonic that I told you? Ulnar. Here this is upper subscapular L is lower subscapular, N is nerve to latissimus dorsi, A you know is axillary nerve, and R you know is the radial nerve. Now instead of this mnemonic, let's use another mnemonic. So this is also known as thoracodorsal nerve, right? Let's use another mnemonic. The mnemonic that we are going to use is going to be stars. It is going to be stars. S-T-A-R-S. Alright, S-T-A-R-S. You can already make out that A here would be axillary nerve and R here would be radial nerve. No doubts? Now these two S's, they will stand for subscapular. They will stand for subscapular nerve. ठीक है, subscapular याद रहेगा इससे. Since there are two, you have to know that one is upper subscapular and the other is lower subscapular. What is left? T. T is now thoracodorsal nerve. Now you know that the thoracodorsal nerve is the nerve to latissimus dorsi. So sometimes you might forget what is this N. You might forget what is this N. So in that case, the mnemonic stars will help you. In that case, the mnemonic stars will help you. So this is basically an idea of this and this. This much clear? Okay. Let's move ahead. If you are clear with these mnemonics. So what I just told you that you can use ulnar. So what are the various mnemonics you can use for the posterior chord? You can go with ulnar. Alright. You can replace this L and U here. You can use lunar. And my recommendation to you would be to remember ulnar and stars together. Okay. So now there are a few things that you should be remembering. There are a few things that you should be remembering here regarding a few of the nerves and what they supply. Alright. Regarding a few of the nerves and what they supply. I have to have some water. First I'll finish this, then I'll have some water. Yeah. So here upper subscapular nerve, since it is the upper subscapular nerve, it will, okay, I'll take you back to this diagram. Yeah. So this muscle here, this is subscapularis. What is this muscle here on the anterior aspect? This entire muscle, that is subscapularis. Here you have the teres minor originating and here you have the teres major originating. Just get an orientation of where you have all these muscles. And then these muscles will go and insert on the head of the humerus, right? So subscapularis, teres minor, teres major. Just remember these muscles here. Anterior aspect mein you have the subscapularis. So since the upper subscapular, it is present upper on the upper side. So it will supply only the subscapularis. It does not come near the spine or near the inferior tip of the scapula, right? So it only supplies the subscapularis muscle, right? Upper subscapular nerve, subscapular muscle. Then lower subscapular nerve, it will supply not only the subscapularis, but it will also supply the teres major. It will supply the teres major, right? Then N is nerve to latissimus dorsi. Obviously, it will be supplying the latissimus dorsi muscle. There is no doubt about it that the thoracodorsal nerve will supply the latissimus dorsi muscle. Then what is left is the axillary and the radial nerves. Radial nerve we will do in detail. Radial nerve we will do in detail. Axillary nerve we will also go in a little detail. There's not much to tell about it. But the axillary nerve, remember, it supplies two muscles, the deltoid and the teres minor. So the lower subscapular nerve, it supplied only the teres major. It said, I am lower, so I will supply only the muscle that is lower. I will not supply the muscle that is present above. And even the upper subscapular did not supply it. So teres minor remain unsupplied. So axillary said that don't worry, I will supply you. So axillary nerve is supplying two very important muscles. One is the deltoid and the second is the teres minor. So teres muscle minor is getting different supply, major is getting different supply. ठीक है, एक बार इसको हम एक अलग तरीके से समराइज करेंगे. So tell me one thing, you have the rhomboids, you have the teres. First, tell me which cord supplies the rhomboids. You're right. No cord supplies the rhomboids. Rhomboids gets its supply from the dorsal scapular nerve, which is a direct branch from the roots. Which is a direct branch from the roots. And here you will have dorsal scapular will supply both the R major and the R minor. Whereas for the teres major and the teres minor, they have different nerve supplies. They have different nerve supplies. Teres major, it will be supplied by the lower subscapular nerve, whereas the teres minor, it will be supplied by the axillary nerve. ठीक है, तो टेरिस वाले जो है ये याद रखना अलग से इंपॉर्टेंट है. ठीक है, टेरिस मेजर को कौन सप्लाई करता है, टेरिस माइनर को कौन सप्लाई करता है, एंड उससे ये आपको अल्नर का सारा याद हो गया. सिर्फ ये आर का डिटेल रह गया थोड़ा सा रेडियल नर्व का. ऑलराइट, now we are done with two chords. We are done with the lateral chord and we are done with the posterior chord. Now what is left is the medial chord. M for medial. एंड इसका निमोनिक क्या था, M for U. M for U. तो 4 M ये हो गए, 1 2 3 4. Now remember I told you that mnemonic posterior chord ulnar, but ulnar nerve is a branch of the medial chord. Ulnar nerve is a branch of the medial chord. Pretty obvious, right? So ulnar nerve here, it will be U. Now what are all these M's? First of all of these you will write medial for all of these. ठीक है, medial 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 medial. ठीक है, 4 medial लिख दिए. उसके बाद रिमेंबर नाउ द ब्रांचेस ऑफ द लैटरल कॉर्ड. ठीक है, लैटरल कॉर्ड में जो दो एल थे वो क्या थे, एल एम एल. दिस वाज मस्कुलोक्यूटेनियस. एल हियर इट वाज लैटरल रूट ऑफ median nerve. It was lateral root of median nerve. Here you will have the medial root of median nerve. Here you will have the medial root of median nerve. And this L was lateral pectoral nerve, which was piercing the clavipectoral fascia. Instead of that, here you have the medial pectoral nerve, which pierces both the P major and P minor. So it will also supply the P minor. So it will also supply the pectoralis minor. So the medial pectoral nerve, it is supplying both P major and P minor, whereas the lateral pectoral nerve only supplies the P major. If I put this statement in a converse way, P major is supplied by two nerves, medial pectoral and lateral pectoral nerve. P minor is supplied by only one nerve, medial pectoral nerve. ठीक है, or you can write it as medial pectoral nerve supplies two muscles, lateral pectoral nerve supplies one muscle. P major is supplied by two nerves, P minor is supplied by only one nerve. Okay, so these first two M's you can directly compare it with the lateral cord. You can directly compare it with the lateral cord. Now two more medials are left. So those two medial nerves are branches that are cutaneous. So you have the medial cutaneous nerve of the arm, alright, medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm. Remember that the lateral cutaneous nerve of the forearm is an extension of the musculocutaneous nerve, alright, it is an extension of the musculocutaneous nerve. This much is clear regarding the chords. Okay, so do you have any doubts regarding the brachial plexus? Do you have any doubts regarding any part in the brachial plexus? If you don't have any doubts, we'll move on to the MCQs of the brachial plexus. We can move on to the MCQs of the brachial plexus if you don't have any doubts so far regarding the brachial plexus. Bas ek baar I'll just summarize the mnemonics. You have the lateral cord, you have the posterior cord, then you have the medial cord. You have two direct branches from the roots, then you have two direct branches from the upper trunk. Here you will have the dorsal scapular and the long thoracic nerve. Here you will have the nerve 2 subclavius and the suprascapular nerve. Right? Lateral you will have LML. Posterior you will have ulnar and or stars. Medial cord you will have M for U. How many branches do you have? 3 plus 5 plus 5, 13, 2, 15 and 17. So these are 17 branches of the brachial. Okay, इतना clear है? Should we move on to these MCQs? Okay. This first MCQ, you tell me the answer. While you tell me the answer, I will just have some water. Can you guys tell me the answer to this question? A, suprascapular nerve, right? So here there is a small catch. There are two options that will seem to be correct. One is A and one is D, right? Both of them are coming from the trunk of the brachial plexus. So the better answer here is the nerve to subclavius. The reason is that the nerve to subclavius, it always comes from the upper trunk, whereas sometimes the suprascapular nerve, sometimes it comes from the roots, sometimes it comes directly from the. So answer is going to be option D, nerve to subclavius. Answer is going to be option D, nerve to subclavius. Okay, so that is why I had kept this question. I just wanted to highlight this point that nerve to subclavius is a better answer. Nerve to subclavius is a better answer than the scapular nerve. Okay, this much is clear. So we are done with. So Mishti has written the absolute correct answer. A and D, you can consider both. Okay, but better answer is D if you have to choose one. But otherwise, both are correct. So that is question number 1 for you guys. Let's move on to question number 2. Let's move on to question number. Of the following nerves does not have the root value C5, C6, C7? Option D, ulnar nerve. Absolutely correct. Answer is option D. Shraddha Sharma and Mishti, both of you have written the correct answer. The answer is option D, ulnar nerve. Now, why is that? You can see it here that the ulnar nerve, it basically supplies the distal muscles. Ulnar nerve is also known as the musician's nerve. Why? Because it supplies the muscles of the intrinsic muscles of the hand. So a musician has to use these fingers. So ulnar nerve, musician's nerve, it supplies the distal muscles. And all these distal muscles, they will be supplied from distal dermatomes, not from C5, C6, C7. So ulnar nerve, you will have the root value will be C7 to T1, C7, C8, T1. So this is the root value of the ulnar nerve, C7, C8, T1. So it will not have the root value C5, C6, C7, which is true for all of these three. Alright, the branches of the lateral cord. Okay. Question number 3. Which of the following nerves carries fibers from all the roots of the brachial plexus? Question number 3. Which of the following nerves carries fibers from all the roots of the brachial plexus? So what were the various roots of the brachial plexus? C5, C6, C7, C8, T1. So which of the following nerve has this root value? This should be the root value of a nerve. Previous year question from NEET. Anatomy 3D atlas is right. The answer is going to be median nerve. So you all know that the axillary nerve, it is not going to be here. It is having its root value is C5, C6. Muscular cutaneous, the root value is C5, C6, C7. Ulnar nerve, we already talked. The root value is C7, C8, T1. Whereas for the median nerve, the root value is C5, C6, C7, C8, and T1. ठीक है तो रूट वैल्यू सी के लिए सही बैठ रही है आंसर इज ऑप्शन 3 क्वेश्चन नंबर 3 the answer is going to be option C. Alright, question number 4. Question number. So guys, that is the benefit of Unacademy. You can see that all of these live quizzes kind of things that we are doing. So I just taught you a topic. After that, I have brought some MCQs for you. You can attempt all these MCQs along with me so that you get a very crystal clear concept of both the theoretical knowledge and how to apply it in questions. So ये एक बहुत अच्छा मीडियम है सीखने का. So and if you take a plus subscription, do use my referral code, that is Chetanya 10, and of course best deal वाली बात तो करी थी मैंने. So Fazi Ahmed Khan has written that the answer is going to be D. Alright. So the question is all are true except about the brachial plexus. All are true except. So you have to find out the false statement. Lower trunk C81 true. Lateral cord upper and middle trunk true. Both their ventral divisions, right? Posterior cord is formed by posterior divisions of all three, again true. C4 root is prefixed, no. Postfixed, no. It is going to be prefixed. So this is incorrect. This is going to be incorrect. Yes, Shraddha Sharma has corrected the statement also. Shraddha Sharma has corrected it also. Question number 5. The dorsal scapular nerve, what does it supply? What does the dorsal scapular nerve supply? The dorsal scapular nerve supplies. Right, so I think Mishti has given the right answer now. Fazzy has also given the answer. Even Amreen has given the answer. Yes, so all of you have answered option A. That is these are the retractors of the scapula. These are the retractors of the scapula. So remember that schematic diagram that I had shown you. I had drawn something like this. And here you had levator scapulae. You had the rhomboid minor. Then you had the rhomboid major. All of these are being supplied by the dorsal scapular nerve, which comes directly from the roots of the brachial plexus. Question number 6. Posterior chord of the brachial plexus is formed by. Question number 6. Root value is C5. Dorsal scapular nerve. The root value is going to be C5. Absolutely correct. Since it is coming directly from the roots, it should also have a direct fixed root value, and it is coming from the C5 root of the brachial plexus. Question number 6. Right. So a lot of you have written Fazi. Everyone has written today. Everyone is giving the correct answers. It seems. So all of you have written the answer is going to be D. Dorsal divisions of all the three trunks. So what are the various chords? Lateral chord, medial chord, posterior chord. Posterior chord में आएगा dorsal of upper, dorsal of middle, dorsal of lower. ठीक है. अब lateral chord में क्या क्या आता है? Lateral chord में अभी हमने बात करी यहाँ पे. There was this question where we said that lateral cord is formed by the upper and middle trunks. It is formed by the upper and middle trunks के ventral divisions, ventral of upper and ventral of middle. तो medial cord में क्या जाता है? Ventral of lower. ये सिंपल सा एक अंडरस्टैंडिंग है कि दो वेंट्रल इधर गए, एक वेंट्रल इधर गया, तीन डॉर्सल इधर गए. दैट इज हाउ these cords are formed. That is how these various cords are formed. Question number 7. All are infraclavicular branches of the brachial plexus except. All are infraclavicular branches of the brachial plexus except. So all are infraclavicular branches except. No. Remember I told you that supraclavicular part of the brachial plexus and there is an infraclavicular part of the brachial plexus. So closer to the clavicle you will have the roots and the trunks obviously, and here you will have the divisions, cords and branches. They will be infraclavicular. So obviously the branches that come directly from the roots or the trunk, they will be supraclavicular branches, and branches that are coming from the cords, they will be infraclavicular branches, right? So ulnar nerve, axillary nerve, thoracodorsal, all of these are branches from the posterior cord. So all of these are infraclavicular branches, but the long thoracic nerve, it comes directly from the roots. So long thoracic nerve is a supraclavicular branch of the brachial plexus. So the correct answer, as pointed out by Mishti, is B. Thoracodorsal nerve is wrong, as Shraddha said, and Faizi has said ulnar nerve, that is also wrong. So I hope you have understood question number 7. What are supraclavicular branches and what are infraclavicular branches of the brachial plexus? Question number 8. All are branches of the posterior chord of the brachial plexus except. All are branches of the posterior chord of brachial plexus except. Again, Shraddha Sharma is saying C, long thoracic nerve. Alright. Mishti has also said C and Amreen has also said C. So it's absolutely right because as you already know, there's a mnemonic is stars. P is thoracodorsal nerve, A is axillary nerve, R is radial nerve. So all of these three are branches of the posterior cord. So it's not going to be this. The answer is going to be long thoracic nerve, which comes directly from the question 9. Posterior cord will supply. Which of these muscles is supplied by the posterior cord? Okay, so you're all answering correctly. The answer is teres minor. So you know that the axillary nerve, it is a branch of the posterior cord. Axillary nerve, it will divide and it will supply both the deltoid and the teres minor. So the teres minor naturally is supplied by the posterior cord. It is supplied by the posterior cord because the axillary nerve, it is a branch of the posterior cord. Last question, question number 10. What is the root value of the thoracodorsal nerve? Root value of the thoracodorsal nerve is. Answer is C, C6, C7 and C8. Absolutely correct. These three. So you know that the thoracodorsal nerve, it is a branch of the posterior cord, supplies latissimus dorsi. And latissimus dorsi is basically why it is being supplied by the brachial plexus. It is actually present in the lower back, but it is actually an upper limb muscle which migrated downward to the lower back for improved function. So that is why it is supplied by the brachial plexus. So remember that the latissimus dorsi muscle, it was actually a muscle of the upper limb, right? It has its attachment here, lady between the two majors, and then it is going towards the lower back. So that is how it has migrated towards the lower back, but it is still having its nerve supply from the brachial plexus. So the nerve supplying it is the thoracodorsal nerve, right? So that is about the MCQs of the concepts of brachial plexus. Now we will move to the injuries of the brachial plexus, where we will cover two things. One will be the Erb's palsy. Second will be the Klumpke's palsy. Sorry, Erb's palsy and Klumpke's palsy. So paralysis or palsy, whatever you want to call it. First, let's talk about what is Erb's point. What is Erb's point? So Erb's point, first of all, it is present in the upper trunk. It is present in the upper trunk. It is a point where you have the confluence of 6 nerves. You have the confluence of 6 nerves, right? Now, what are those 6 nerves? So, what were the two branches from the upper trunk? One was the suprascapular nerve. The other was the nerve to subclavius. So, these were two nerves coming from the upper trunk. Then the upper trunk by itself was dividing into the anterior and the posterior divisions. So first, those are the two nerves, the anterior and the posterior division of the upper trunk itself, and the roots from which it was coming, the C5 and the C6. Those are another set of nerves. So 1, 2, 3, 4, 5, 6. Now this is known as Erb's point. So usually Erb's palsy is a damage here at the level of the upper trunk, So the root values that are involved here are C5 and C6. You will lose all the nerve supply that is coming from the C5 and the C6 if there is a damage to the upper trunk at the Erb's point, Erb's point. Okay, so this sixth nerve meeting is called as Erb's point, and this is its damage is known as the Erb's palsy, where the root values involved obviously will be C5 and C6. Clear? C5 and C. So now if you talk about C5 and C6, if you look at this, if you involve these two root values, there are two nerves that you should think about. There are two nerves that you should think about when you talk about C5 and C6 here. First, you should be thinking about the axillary nerve. First, you should be thinking about the axillary nerve. Alright. Why axillary nerve? Because its root value is C5 and C6. No fibers from C5, C6 will be able to enter any of the branches of the brachial plexus if there is Erb's palsy, right? And axillary nerve, what were the two muscles that it was supplying? One was the deltoid and the second was teres minor. Second was teres minor, right? So since it supplies the teres minor and the deltoid, and main function here, functionally very important, is the deltoid. So there will be an injury to the deltoid muscle. There will be an injury to the deltoid muscle. Alright. Second, there will be injury to the musculocutaneous nerve, where you have three root values, C5, C6 and C7. Alright. C5 and C6, they are supplying biceps and brachialis. They are supplying two muscles, biceps and brachialis. But coracobrachialis, it is also supplied by C5, C6, but it is predominantly supplied by C7. So coracobrachialis is spared. Alright, so musculocutaneous nerve, you will read later, it supplies, I'll just tell you that it supplies the biceps, it supplies brachialis, and it supplies coracobrachialis. So how I remember this is as mnemonic is BBC. Alright, I remember it as BBC. British Broadcasting Corporation, or you know that there is another full form for BBC. Okay, so biceps, brachialis and coracobrachialis. Biceps, brachialis and coracobrachialis, where biceps and brachialis will be completely damaged, whereas coracobrachialis will be spared because it also has nerve supply from C7. It has main nerve supply from C7. Alright. So Erb's palsy, upper trunk, you will have injury here. Suprascapular nerve is gone, axillary nerve is gone, musculocutaneous nerve is gone, and there is also partial damage to the radial nerve. There is partial damage to the radial nerve. This injury can occur due to a fall on the shoulder, or it can be due to a birth injury. And the deformity is the policeman's tip hand. Why is there policeman's tip hand? Because remember here that the abduction of shoulder, it is done by deltoid. So deltoid is damaged, the shoulder will be adducted like this, and it is a lateral rotator. So you will now have medial rotation like this. Alright. First, there is no abductor. So, and this, let's have a look at this. This is your deltoid. Deltoid is responsible for abduction. Deltoid does not work. So there is no abduction. Their hand is adducted. Hand is adducted. Why is there medial rotation? Deltoid is also a lateral rotator. So there is medial rotation at the shoulder joint. The elbow, you have the flexors are damaged. Biceps and brachialis are damaged. So at the elbow joint, what you will have? You will have extension. You will have extension. The biceps is responsible for supination. You will have pronation. You will have pronation. So it will look like you are trying to receive a tip. You are trying to take some bribe, or you take a tip as a waiter. This is known as policeman's hand or waiter's tip hand. And is the Erb's palsy. Remember this Erb's palsy. Alright. So deltoid, you will have adducted shoulder because of deltoid, adducted and internally rotated. Adducted and you will also have internally rotated shoulder. Whereas because of biceps and brachialis damage to biceps and brachialis, which are biceps, you know, is also responsible for supination of forearm, and together they are also responsible for flexion of arm at the elbow joint. So you will have extended elbow and pronated forearm because supination is damaged. So this action, remember, is the policeman's or porter's or the waiter's tip hand, and it is seen in the Erb-Duchenne fallacy. Alright, Erb's fallacy. So you can simply remember it as Erb's fallacy. Got it? Now let's talk about another kind of palsy known as the Klumpke's paralysis. Another type of paralysis known as the Klumpke's paralysis. What were the root values there? C5, C6. The root values here, you will skip C7. Root values now are C8 and T1. Root values involved in Klumpke's paralysis. So, Erb's palsy, let me write here. It is known as upper brachial plexus injury. Upper brachial plexus injury. Coming to Klumpke's, is known as lower brachial plexus injury. It is a lower brachial plexus injury. Now, what all will you have if you have a lower brachial plexus injury? You will have damage to the intrinsic muscles of the hand. It will be, because remember the C8 T1, again it will be present in the ulnar nerve. So you will be supplying, they will be supplying the distal most parts of the hand. Alright, the distal most parts of the upper limb. That is the hand. So there is damage to the intrinsic muscles of the hand, because of which you have hyperextension at the MCP joints and flexion at the interphalangeal joint. So you will have the claw hand. You will have the claw hand. Alright, you will have the claw hand because of that. Okay. So here you will see that median nerve will be injured, ulnar nerve will be injured, and there is also damage to T1. So if you remember that the sympathetic fibers are coming from a thoracolumbar outflow, and these T1 sympathetic fibers, they are responsible for innervating the levator palpebrae superioris. So because of that T1 damage, this causes Horner syndrome. This causes Horner syndrome. Why? Because these sympathetic fibers, if they get damaged, that causes Horner syndrome. So you will have claw hand deformity plus Horner syndrome, and its causes can be birth injury or hyperabduction of the arm. Right? There will be drooping eyelids. You will have ptosis here, right? That is characteristic of Horner syndrome due to damage of T1. Claw hand and Horner syndrome are characteristics of Klumpke's paralysis. ठीक है, तो एक बार let's summarize this again. टू है, एक है Erb, एक है Klumpke. यह है upper 5C6, ये है lower 8 T1. यहाँ पे क्या होगा? क्लॉ हैंड. यहाँ पे क्या होगा? क्लॉ हैंड. और दूसरा क्या होगा यहाँ पे? Horner. यहाँ पे क्या होगा? Policeman's tip hand. Right? Now let's move to question number 1. Question number 1. All of the following muscles undergo paralysis after injury to the C5 and C6 spinal nerves except. All of the following muscles undergo paralysis after injury to the C5 and C6 spinal nerves except. Yes. So I've got an answer from Mishti, that is B, and I've got an answer from Shraddha, that is D. Alright. I've got two answers. Okay, Shraddha has also changed her answer to B. So since she's changed her answer, you know that it's obviously right. So answer is going to be biceps is obviously damaged. Biceps brachialis, even brachioradialis is damaged. The only muscle that is spared here is coracobrachialis. Muscle that will be spared here will be coracobrachialis. Why will coracobrachialis be spared? Because it has its predominant supply. It has its predominant supply from C7. C5, C6, C7 होता है, and coracobrachialis predominant supplies from C7. Alright, so this is spared. Answer is going to be option B. Question number 2. Injury to the upper trunk of the brachial plexus results in injury to the upper trunk. Injury to the upper trunk. Now, what is an upper trunk injury of the brachial plexus called as? Right. So the answer is, so there are multiple options which are correct. Right. There are multiple options here that are going to be correct. One of them is C. You will not be able to initiate abduction. Right. You will have paralysis of deltoid muscle. Alright. This is definitely correct. Paralysis of deltoid muscle. E is going to be correct. Then C is also going to be partially correct. Right. Then will there be supination of the forearm? No. There will be pronation of the forearm. External rotation of the arm? No. There will be internal rotation of the arm. And decreased sensation on medial side? No. Decreased sensation on the lateral side. E and E are the correct answers. I hope you can correlate with the policeman's tip hand. You can correlate with the policeman's tip hand. Question number 3. True about the upper trunk of the brachial plexus. What is true about the upper trunk of the brachial plexus? Question number 3. What is true about the upper trunk of the brachial plexus? Tell me an answer at least. Why are you people taking so much time? Fast, quick, quick, quick. E can be blocked medial to the scalenus anterior muscle. Okay. Is there any other answer? Shraddha is saying answer is B. She's saying the answer is D. Right, obviously radial nerve, it gets some of its component from the upper trunk. So if you have a lesion of the upper trunk, there will be partial injury of the radial nerve. So the answer is going to be D. The answer is going to be D. Question number 4. False regarding Klumpke's paralysis. False. Which of the following is going to be false regarding Klumpke's paralysis? This one is an easy question. Okay, so yeah, Shraddha Sharma said, told the right answer. The answer is going to be D. Not the upper trunk, but the lower trunk of the brachial plexus is involved. The lower trunk of the brachial plexus is involved. Question number 5. You read the question. Meanwhile, I'll just go to the washroom. Excuse me. Sorry. Okay. I'm back, guys. Sorry about that delay. So, 19-year-old boy fell from the motorbike on his shoulder. So, there has been a fall on the shoulder, right? So, I think you all have been able to answer. Some of you have answered C, some of you have answered D. I think most of you have given the answer as C. Loss of pronation नहीं होगा, ठीक है? So there's a fall on the shoulder. So fall on the shoulder means Erb's palsy. Yes. So doctor has diagnosed him. The following signs and symptoms will be observed except. So which of the following is not a sign and symptom of Erb's palsy? So you have loss of abduction because of damage to deltoid. You have loss of lateral rotation because of damage to deltoid, and you have loss of pronation. No, you have loss of supination because of damage to biceps, and you have loss of flexion because of damage to biceps and brachialis. All right. So answer is going to be option C. Answer is going to be option C. Very crystal clear question. Question number 6. A young boy who was driving a motorcycle at a high speed collided with a tree and was thrown on his right shoulder. So basically, guys, these questions of aims, this is how your next pattern questions are going to be, right? If you look at this question, this is a very clinical and practical question. So that is how your clinical questions will be coming in the next examination. So yeah, do you have an answer? So answer given by Shraddha Sharma is C. Let's see. Young boy was driving motorcycle, collided with a tree, was thrown on his right shoulder. Again, it should be Erb's palsy. There was no fracture. Right arm was medially rotated and forearm is pronated. That further confirms our diagnosis of an Erb's paralysis. Following facts are correct except. So you have to tell the incorrect statement. Injury was at the Erb's point. This is true for Erb's palsy. Lesion of C5, C6 again true. Medial and ulnar nerves are affected. No, this is false. Medial and ulnar nerves. You know that the median nerve, it comes from median and ulnar, they won't be affected because ulnar, the root value is C7, C8, T1. Okay, even for the median, it is C5, C6, C7, C8, T1. So the ulnar will definitely not be affected. So the answer is going to be option C. You know the supraspinatus, infraspinatus, subclavius, and biceps have to be involved. Nerve to subclavius will be damaged at the Erb's point, and then supraspinatus, infraspinatus, they will also again root value is also C5, C6, and biceps is also damaged. So question number 7, concerning brachial plexus, which of the following facts are true? So this is a multi-answer correct. Multi-answer correct. Question number 7. Answers. So question number 7. Anybody knows the answers? So facts are true. Formed by spinal nerve C4 to C7, wrong. It is formed by C5 to T1. Most common site of injury is upper trunk. This is true. Erb's paralysis is the most common site of injury of the brachial plexus. Injury occurs during breech delivery. Yes, you can have both clumpies and Erb's during breech delivery. B and C are correct. Radial nerve is a branch of the medial cord. No, this is false. It is a branch of the posterior cord. And lower trunk injury results in hand deformity. This is again true. So answer is going to be B, C, E. You have claw hand in the uh, Klumpke's paralysis. So you have B, C, E. Correct answer. Now let's move on to, okay. So we're done with brachial plexus. We're done with brachial plexus from my side. So what we have done so far is we have done brachial plexus. Plus we have done Klumpke's paralysis, and plus we have done Erb's. Plus we have done 15 MCQs. So that's a lot that we have covered. Now I'm moving to, before we move to the radial, median and the ulnar nerves, I want to cover two small nerves. That is, first is the axillary nerve. Second nerve that I will cover will be the musculocutaneous nerve. Alright. So let's talk here about the axillary nerve. What is the root value of the axillary nerve? You should know C5 and C6. So axillary nerve, the root value is C5 and C6. That is the first thing you have to know about the axillary nerve. Then second thing you should know is that since it is a nerve that crosses the shoulder joint, so Hilton law says that it should supply the shoulder joint. So it is supplying the shoulder joint here, right? Then it will divide into an anterior and the posterior branch. It will divide into the anterior branch and the posterior branch. The anterior branch gives a branch to the deltoid, and it also gives a cutaneous branch to the lower half of the skin over the deltoid. Alright, it gives a cutaneous branch here. Then the posterior branch, first thing it does is it gives a branch to the deltoid. Then it forms another branch which also has a pseudoganglion which goes to the teres minor, So what are the two muscles being supplied? The teres minor and the deltoid. The teres minor and the deltoid, these are the two muscles being supplied by the axillary nerve, and the posterior branch is giving a division which is forming a pseudoganglion. So remember, the axillary nerve forms a pseudoganglion. Axillary nerve forms a pseudoganglion, and this posterior branch will give the upper lateral cutaneous branch of the arm to the skin of the lower lateral part of the deltoid. So it also has some cutaneous innervation. No need to go into the details of the cutaneous innervation. But yeah, both of them have some cutaneous innervation, and they are supplying two muscles. One is deltoid and the second is teres minor. So that is what you need to remember about the axillary nerve. Chalo, I'll tell you what all you should remember. Axillary nerve. Try to remember the root value. C5, C6. Try to remember the muscles supplied. Deltoid and teres minor. Besides that, you can also remember that it supplies the shoulder joint, and cutaneously it supplies skin over deltoid is what you can remember. Skin over the deltoid. Okay, so that is about axillary nerve. Second nerve is the musculocutaneous nerve. Second nerve is the musculocutaneous nerve. A musculocutaneous nerve, first you should know the root value. That is C5, C6, C7. Alright, that is the root value of the musculocutaneous nerve. Then first it supplies which muscle? Coracobrachialis. It supplies it in the axilla. It supplies the coracobrachialis in the axilla first. Right? Then in the arm, it supplies two muscles, biceps brachii and brachialis. It supplies biceps brachii and it supplies brachialis. Then it also gives a branch to the elbow joint. And last point that you have to remember is that it continues as the lateral cutaneous nerve of forearm. Okay, so that is all you need to remember here about the musculocutaneous nerve. These are all the points. 1, 2, 3. Okay. Just again you have to remember that the coracobrachialis is spared because it is predominantly getting supplied by C7. Now let's move to the major nerves. So what all have we done? We have done brachial plexus, I have done axillary nerve, I have done musculocutaneous nerve. Now what is left are the major nerves, that is the radial nerve, median nerve and the ulnar nerve. So we are halfway there, halfway left. So let's start with the radial nerve. Should we start with the radial nerve? Can you please write a yes in the chat box if you are ready to start with the radial nerve? Can somebody write a yes in the chat box if you're watching live? Okay, Shraddha has written a yes, so I will continue with the first topic for today, that is the radial nerves from the three major nerves. So look at this diagram. This is a schematic diagram that I have drawn to show you exactly how the radial nerve moves, and after that I will show you more realistic diagrams. ठीक है, तो ये बिल्कुल schematic diagram है to get an understanding of how the radial nerve moves, and this understanding is important because this will help you understand the various levels of injuries and what gets affected in what injury. ठीक है, first thing that you have to remember is that the radial nerve is a nerve that supplies extensors, is a nerve that supplies the extensor compartment, whether it be the arm, whether it be the forearm. It mainly wants to supply the extensors. Alright, that is the first thing. Second thing, you have to remember its course. Now it starts in the axilla, and it supplies the triceps at 2 points. It supplies the triceps at 2 points. One in the axilla and other in the radial or the spiral groove. So in the axilla, it supplies two heads of the triceps. One is the long head of the triceps. One head that it supplies is the long head of the triceps. Alright, it supplies the long head of the triceps. Then it supplies secondly the medial head of the triceps. Supplies the long and the medial head of the triceps in the axilla. Then after it leaves the axilla, it moves along the shaft of the humerus in the radial groove or the spiral groove along with the profundi brachii vessels. Alright, it moves on the shaft of the humerus, the spiral groove, where it gives a few nerves. It supplies few nerves. One of them is to the triceps again. So previously it had supplied the long and the medial heads. Now you have to remember that the medial head is the largest head of the triceps. So if it is the largest head of the triceps, उसकी एक बार में भूख नहीं मिटती. It has to be supplied twice. उसको दो बार सप्लाई देना पड़ता है. तो एक बार axilla में, and again the triceps are supplied in the spiral groove along with the lateral head of the triceps, ठीक है. So the medial head of the triceps, it is supplied twice, once in the axilla, second time in the spiral groove. In the axilla, the long and the medial heads are supplied. In the spiral groove, the medial and the lateral heads are supplied. Now after it exits the spiral groove, it has to course further downward. So it was moving here, and then it crossed along the spiral groove, it went downward, and now it has to cross here. Now remember that the radial nerve, it moves downward over the lateral epicondyles. Okay, let's trace the course. In the axilla, it was present initially in the axilla. It crossed the spiral groove. It went to the lateral side. On the lateral side, it now has to move over the lateral epicondyle. So remember, the radial nerve, it crosses the lateral epicondyle anteriorly. It crosses over the lateral epicondyle like this, crosses over it and divides into two branches, the superficial and the deep branch. It divides into two branches, the superficial and the deep branch. Before it moves forward over the lateral epicondyle, it directly gives two branches. One is a branch to the brachioradialis. Second is a branch to the extensor carpi radialis longus. Now this is an important branch to remember. Okay, so all the extensors here, they are being supplied after it has divided into the superficial and deep branches. But the extensor carpi radialis longus, this branch for the extensor carpi radialis longus, this is given at a much higher level, even above the epicondyle. So if there is a fracture at this level, this extensor carpi radialis longus is spared, which is a powerful extensor of the forearm. Sorry, powerful extensor of the wrist. After talking about the extensor carpi radialis longus, we will say that the nerve, it moves here, moves here, moves here, and it crosses over the lateral epicondyle. Very important to remember. Later I will tell you that there is another nerve that goes deep to the medial epicondyle. Here we are talking about the lateral epicondyle, and the radial nerve moves over it. It moves over it. Then it divides into two. One is the superficial branch. One is the superficial branch. And the superficial branch, where have you studied it? It is a content of the cubital fossa. Remember MBBR, MBBS, median nerve, brachial artery, tendon of biceps, and superficial branch of the radial nerve. So it is a content here of the cubital fossa that you have to remember here. Cubital fossa. And then after the superficial branch goes from here, it keeps moving, and then as you remember, it goes to the snuff box. It goes to the anatomical snuff box, right? So that, don't worry, I'll talk about all the injuries of the radial nerve. I'll tell you when you will have wrist drop, when you will have finger drop, when you will have flexed elbow. ठीक है, अभी सब बात करते हैं. That is about the superficial branch. Now what about the deep branch? So the deep branch, why is it called deep? Because it goes deep to the supinator muscle. Okay. So all the three nerves, the radial, median and ulnar, they're all related to one particular muscle, which they either pierce or they pass between the heads. Okay. So this nerve, the radial nerve, it pierces the supinator muscle. It goes through the supinator muscle and it continues as the posterior interosseous nerve. It continues as the posterior interosseous nerve. Continues as the posterior interosseous, and this posterior interosseous nerve, it will supply all the extensors here that are present in the forearm in the posterior compartment. For example, your main extensor that you can remember here is the extensor digitorum. So tell me, if there is a damage to extensor digitorum, so you will not be able to keep these fingers extended, so there will be finger drop. Okay, because of damage to the posterior interosseous nerve, because it supplies the extensors of the digits, there will be finger drop. If these extensors are damaged, there will be wrist drop. And if this triceps is damaged, you will not be able to keep the elbow like this. There will be flexed elbow. You will not be able to extend this. All right. So are we clear with the course here of the radial nerve? It starts in the axilla, and the axilla, it supplies two heads of the triceps, the long and the medial head, goes into the spiral or the radial groove where it supplies the medial and the lateral head of the triceps, moves out of the radial groove and gives two branches, one to the brachioradialis, second to the extensor carpi radialis longus, then passes forward to the lateral epicondyle, over the lateral epicondyle, divides into the superficial and the deep branches. The superficial branch continues forward and it goes through the cubital fossa. It is the content of the cubital fossa, then goes to the anatomical snuff box, and there it has some cutaneous innervation, alright, which I have not talked about yet. In the deep branch, it passes through the supinator muscles, forms the posterior interosseous nerve. So remember, the posterior interosseous nerve, it is a branch of the radial nerve, not the anterior interosseous nerve, only the posterior interosseous nerve, and this will be supplying all the extensors such as the extensor digitorum, and damage to these extensors causes finger drop. All right. Now, what about the cutaneous innervation of the superficial branch? All right. Let's talk about that a little. So this cutaneous innervation, if you look at this, this is the dorsum of the hand. Alright, this is the dorsum of the hand. So the radial nerve, it is present on the lateral surface. Is it present on the lateral surface? So basically what happens is, here the radial nerve, it is present here on the lateral surface. So if you look at the dorsum of the hand, this is the thumb, this is the first digit, this is the second digit, third and fourth, right? So the lateral 3.5, 1, 2, 3 and half of this, half of the ring finger. So 1, 2, 3, half. Alright, that is what you have done. 1, 2, 3, half. 3.5, lateral 3.5 digits of the dorsum of the hand here are supplied by the radial nerve, except these fingernail beds. Except these nail beds. These nail beds, they will be supplied by the median nerve itself, which supplies the palmar aspect also. Supplies the palmar aspect also. So the nail beds, they are not being supplied here by the radial nerve. They are being supplied by the median nerve. But remaining lateral 3.5 of the dorsum of the hand, it is supplied by the radial nerve. Alright. This is a more diagram to understand the course. Here you can see you have a lateral cord, you have a medial cord, you have a posterior cord. The posterior cord, it gives off an axillary nerve which coils here around the surgical neck of the humerus, which can get damaged while you are giving a injection here, right? And this is the radial nerve. It continues in the axilla, gives a branch to the lateral head and the it gives a branch to the long head and the medial head in the axilla, continues forward, gives branches to the triceps again in the spiral groove. After it exits, it gives branches to the brachioradialis and extensor carpi radialis longus. Alright, and then it will move further downward, form the superficial radial nerve. Alright, it will form the superficial radial nerve, which gives cutaneous innervation here, and it gives cutaneous innervation to your 3.5. Alright, it gives cutaneous innervation to 3.5 of this dorsum of the hand, and then it gives the deep branch forms the posterior interosseous nerve, which will supply these various extensors: extensor carpi radialis brevis, digitorum, digiti quinti proprius, carpi ulnaris, spinator, abductor pollicis longus, extensor pollicis brevis, blah 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 blah. Alright, so all of these muscles, they are being supplied here. Okay, so एक चीज important है regarding its sensory distribution. Okay, Shraddha Sharma is talking about Saturday night palsy. I'll tell you that there are two angles to Saturday night palsy. Alright, two kinds of lesions can be called as Saturday night palsy. In this sensory cutaneous distribution of the radial nerve, you can see that it is supplying some of the back of the arm here, some back of the forearm. Then we already talked that it supplies the lateral 3.5 digits. Now there is a digit here. This is the first webbed space. This is the first webbed space, and it is an isolated supply of the radial nerve. Alright, what do I mean by isolated supply? That there is no other dermatome, no other nerve that will innervate this region. If radial nerve is damaged, there is no compensation for this region, and that is the place where you will check for sensory loss due to damage to the radial nerve. First webbed space. Alright, first webbed space is supplied exclusively by the radial nerve. Okay? So I hope you can remember this diagram. The schematic is much more easier to clear your concepts, and this is much easier to help you get a realistic picture of how the radial nerve is coursing through your entire arm. Alright, again this is a similar representation of that. You can see here which heads are supplied. Then you have it accompanying in the spiral groove with the profundi, brachii artery, gives a branch to the anconeus also in the spiral groove, pierces the lateral intermuscular septum. Remember, this pierces the lateral intermuscular septum, gives a superficial branch, and then also it gives a deep branch. Deep branch will be supplying various muscles. Okay, and the superficial branch will be continuing here, giving cutaneous innervation. Okay, and these are the various muscles which will be supplied. Now there are four kinds of lesions. 1, 2, 3, 4. There will be 4 possible levels of lesions of the radial nerve, and according to where the lesion has taken place, you will have different signs. You will have different kinds of appearance or a different kind of presentation of that kind of an injury. Okay, so let's start with what are the various levels possible for lesions. So the first kind of lesion that takes place is known as the axillary lesion, which will take place here when the radial nerve has just begun. When the radial nerve has just begun. Now that is known as the crutch palsy, or sometimes it is also known as the Saturday night palsy. ठीक है, अब ये दो तरह की Saturday night palsy क्या है ये समझते हैं थोड़ा सा. First, let me just simply list the lesions, then I'll go to explanations. First, you can have lesions of the axillary. You can have the lesion at the axillary level. Second, you can have lesion at the radial or the spiral groove. Third, you can have the lesion at the level of the lateral epicondyle, which is a lateral epicondylar fracture, and you can have it distal to the deep branch. So that is basically a posterior intraosseous nerve lesion. Yeah, so all these lesions are listed from proximal to distal. Proximal to. So remember one thing, a lot of books will write Saturday night here, and some books will also write Saturday night here. It is very confusing that which one is actually Saturday night palsy, but it doesn't really matter. These both are Saturday night palsies, but both are different kinds of Saturday night palsies. Alright, that is more important to understand. Yes, I'll have to take some warm water. So now, which is the Saturday night? How is the axillary lesion a Saturday night palsy, and how is the radial groove lesion a Saturday night palsy? So let's first talk about the radial groove lesion. So what do people have on Saturday night? Why is it being called a honeymoon palsy? Because it also occurs on a honeymoon, and it will also occur on Saturday night. So honeymoons, couples, first time they're having sex mostly, and after that they will lie down together. Saturday night also people are sleeping together, so they will lie down with each other. So the girl might keep her head on the guy's shoulder, or vice versa. The guy might keep his head on the girl's this arm wala region. If they lie down here, the girl will be here. There is going to be a lot of pressure on this, and that pressure will be applied throughout the night. And if that posture gets very uncomfortable, there might be damage to the radial nerve here in the spiral groove. Okay, because of the other partner lying down on this arm. The other partner lying down on this arm, there might be a lesion, or there might be the damage here to the radial nerve. So that is one kind of Saturday night palsy. The second kind of Saturday night palsy is people have a lot of drinks on Saturday night, right? So after drinking, they will get tired, they will sit down on a chair and they will sleep on a chair. So some of these chairs, they have this armrest, and they might sleep like this with the armrest stuck here, like a crutch, like a crutch. So it can be due to the overusage of that crutch, or it can be due to that chair on which you will sit down, sleep after having lots of drinks on a Saturday night. So that can also be a Saturday night palsy. This can also be a Saturday night palsy. Depends on what kind of a Saturday night you are having. Alright. So that is the first thing that I wanted to stress here. Second, this is also known as the crutch palsy. Already you know why. This is known as the honeymoon palsy. You know why. Lateral epicondyle पे कुछ lesion होगा तो उसको कहेंगे lateral epicondylar fracture, and then it can be even distal, which is the posterior intraosseous nerve. First, let's talk about the crutch or the Saturday night palsy at the level of the axilla. Crutch palsy की बात कर रहे हैं mainly. So if the damage is at the level of the axilla, very simple. Concept is very simple then. You will have damage to the all the muscles that were being supplied. So let's look from here. So you have damage at this level. At this level. We take a red pen. You have damage here. So what all is gone? Everything that it was supplying, it is disturbed now. So first of all, triceps are completely gone. So you will not be able to extend your elbow. You will have to have a flexed elbow. First thing that will be there will be a flexed elbow. Second, your extensors are gone. Your extensors are gone. So there is wrist drop. There is wrist drop because you cannot keep your wrist straight. Your wrist is dropped. You cannot keep your fingers straight. So there is finger drop. So there is wrist drop and there is finger drop. So that is somehow what the patient would look like. Alright, with the hand in which there is a damage. There is flexed elbow. There is wrist drop. There is finger drop and there is also sensory loss here, especially in the first web space, So, do you want me to write it down? Alright, it is written here. So, the lesion is in axilla, also known as crutch palsy or Saturday night palsy with arm draped over the chair. You will have loss of elbow extension, so you will have triceps paralysis. So, I will write here flexed elbow. Then you have wrist drop, then you have finger drop, and you will have difficulty in supination. Why you will have difficulty in supination? Because these muscles, they will also play a role when you have to perform the supination part, and you will have some sensory loss. The complete radial nerve sensory region, it will have loss of sensory supply. Then second area of lesion is the spiral groove. Second area of lesion is the spiral groove, where you can have it because of a Saturday night palsy of honeymoon, or it can be due to an intramuscular injection, or it can be due to a mid-shaft fracture. Here the triceps is spared. You will not have a flexed elbow, although there will be weakness of the triceps. But remember here that the triceps was also being supplied in the axilla. Triceps was also being supplied in the axilla. So it is more or less spared. There is some part that is supplied, this lateral head, that will be a little weak. But otherwise you will be able to extend your elbow. Alright, there will be no problem in extending the elbow. The elbow extension is possible, but you will still have wrist drop, you will still have finger drop. So these two things will still be there. The sensory loss will be lesser, right? And if you move to the elbow, that is the region of the supracondylar fracture, or an epicondylar fracture, right? So there you will have, like I told you here, it is the lateral epicondylar fracture. Since above the lateral epicondyle, you had the origin of extensor carpi radialis longus. Alright, since this extensor is active now, this is spared. Extensor carpi radialis longus is spared. So this extensor will be able to compensate, and it will be able to keep the wrist in extended position. So there will not be wrist drop, but there will still be finger drop. Alright, no wrist drop, but still finger drop will be there. So remember here, ESRL is extensor carpi radialis longus is spared, so there is no wrist drop, but there is also finger drop and there is sensory loss. And a distal fracture to the posterior interosseous nerve, that will have, you will not again have wrist drop, you will only have finger drop, and there will also not be sensory loss, since the sensory supplies through the superficial branch. The posterior interosseous nerve does not have much of a cutaneous supply. Okay, so this is clear. Axilla lesion, spiral groove lesion, elbow lesion, and then you have posterior interosseous nerve lesion. As the superficial nerve has divided, you will not have any cutaneous loss. Question number 1. Which of the following is not seen with lower radial nerve injury? Please allow me to have some water. Meanwhile, can you tell me what the correct answer here? So Shraddha said the correct answer is option A. Right. That's absolutely correct. There will not be a weakness of the brachioradialis. Why? Because after the spiral groove, this brachioradialis branch, it is given quite early. It is given even above the lateral epicondyle, right? So this branch to brachioradialis, it is given quite early. So brachioradialis is spared. There will not be a weakness of the brachioradialis, right? Inability to extend fingers will be there. Yes, there will be finger drop. Paralysis of extensor carpi radialis brevis. All right. Will this be there? Yes, because extensor carpi radialis longus is spared, but extensor carpi radialis brevis is definitely damaged. All right, because this is supplied by the posterior intraosseous nerve. And what about loss of sensation? This will also be there. That is about question number 1. Moving on to question number 2. All is true about radial nerve except. Question number 2 is relatively easy. Question number 2. Yes, absolutely correct. Answer is going to be option A. Shraddha has not written the answer, but she has written the explanation that it is actually a continuation of the posterior chord, not a continuation of the lateral chord, right? Absolutely correct. So it is a continuation of the posterior chord. So option 2, the question 2, the answer is going to be A. Now I wanted to show you what a cock-up splint is, right? Because it is used for its injuries in the radial groove. Because if there's an injury there, you will have weakness of this wrist extensor. So the wrist will keep dropping. So to prevent that, this is a cock-up splint. This is a cock-up splint, and it will prevent your wrist from dropping again and again. Alright, it will keep your wrist straight. So question number 3. The following muscles are supplied by the radial nerve below the spiral groove except. Following muscles are supplied by the radial nerve below the spiral groove except. Question number 3, can you give me the answer quickly? The anconis, absolutely correct. Brachialis, brachioradialis, and extensor carpi radialis longus. These branches, they come after the radial groove, right? They come after the radial groove. Excuse me. Sorry, that was a pretty loud one. So yeah, so these three branches, they are given after the spiral groove. Even though extensor carpi radialis longus is given before the lateral epicondyle, it is still given after the spiral groove, right? So the answer here is going to be anconis. Anyways, question number 4, which is true about the radial nerve. This is a question of PGI, so it can be multi-answer correct. Not have partial nerve. Multi-answer correct. Which is true about the radial nerve. Quick answer for question number 4. Multiple answers correct. You all know that it is a branch of the posterior chord, so come on, A is definitely correct. Nerve of the extensor compartment, I just told you that yes, it supplies most of the extensors. So A and B both are correct. T5 to C8 and T1, yes, C is also definitely correct. A, B, C is also correct. Supplies skin of the extensor compartment, yes, this is also true. It has cutaneous innervation of the skin. Anterior interosseous nerve is not a branch of it. Anterior interosseous nerve comes from the median nerve. So here you will have posterior interosseous nerve is a branch of it. Okay, so this is a wrong statement. The answer is going to be not just ABE, it is going to be ABCE. Okay, Mishti? ABCE. Question number 5. Radial nerve passes through the radial groove, the other is. There are 3 nerves that pass through the radial groove. You mainly study about the radial nerve, but there are also 2 other nerves, 2 small nerves that are also passing through the radial groove. Okay. Question number 5, that's why I've kept this question, so that you know that there are 3 nerves that are passing through the radial groove. This has come in your NEET examination in 2014, NEET PG. Yes, so the answer is going to be option D, lower lateral cutaneous nerve of the arm. So 2 nerves. So what are the nerves that pass through the radial groove? Let's just write them. Lower lateral cutaneous of forearm, posterior cutaneous of arm, radial. Although this isn't very important per se, but just because it had come in the examination previously is why I'm telling you this. So lower lateral cutaneous nerve of arm and posterior cutaneous nerve of forearm. Oh, did I say forearm here? Yeah, so this is arm, this is forearm. They are given in the radial groove. Just remember the statement along with the. Okay, so next is question number 6. Important again. Like I stressed on this point specifically. There's something similar in the lower limb as well. Yeah. So anterior part of the lateral epicondyle. Yes. So like I told you that ये lateral epicondyle रहा, ये medial epicondyle, ये lateral epicondyle. Radial nerve it divides here, right? It does not go posteriorly, it remains anterior to this and it divides into the answer here is going to be option. Question 6, the answer is option. Question number 7. Finger drop with no wrist drop. Finger drop with no wrist drop is caused by a lesion of. I just told you that in which case you will have finger drop without wrist drop. You can also think this very logically. Finger drop is occurring why? Because these extensors that are going to the digits, extensor digitorum, they are damaged, and wrist drop can be spared if the lesion is below where you have the branching of the extensor carpi radialis longus. The extensor carpi radialis longus will save wrist drop, alright, if it is spared. So yes, the answer is going to be B if the lesion is at the level of the posterior introitious nerve. Because the posterior introitious nerve, it will supply, it gives off extensor digitorum, right? It gives off extensor digitorum. And extensor digitorum, if it is not working, you will have finger drop. But why there is no wrist drop? There is no wrist drop because extensor carpi radialis longus, which is coming above the lateral epicondyle, that is spared if the lesion is at the posterior introitious nerve, and that can prevent wrist drop, So question number 8, all are affected in low radial nerve palsy except. These lesions of these nerves and the brachial lesions of the brachial plexus, the nerves and the radial and the medial and the ulnar nerves, they are very important. Radial, median and ulnar, बहुत important lesions हैं इनके. Because a lot of these questions are always clinical, so they have more chances to be asked in the coming years since we are shifting to the next pattern. So you're saying extensor carpi radialis longus, that's absolutely correct. The answer is going to be option A because this, I've repeatedly told you, this nerve is coming even above the lateral epicondyle. These won't be spared, but the ECRL will be spared. Alright. So question number 9. Injury to the radial nerve in the lower part of the spiral groove may result in all except. It is, remember, it is occurring in the lower part of the spiral groove. What will not happen? Will Misty, it will result in paralysis of anconeus muscle. Why? Because remember the branch for anconeus, it was arising in the spiral groove itself. So B may definitely occur. Answer is not going to be B. It will weaken the supination movement. So answer will not be C. Answer will not be D and C also because extension will not be extension will be left intact because triceps is functional. But the nerve supplied to the extensor carpi radialis longus, that is not going to be spared. That is not going to be spared because that is coming after the spiral groove. Alright. So nerve to extensor carpi radialis longus, it is coming after spiral groove, that is distal to spiral groove. But it is still proximal. It is still proximal to the lateral epicondyle. Okay, so question number 9, the answer is going to be A. Next, question number 10, injury to the radial nerve at the wrist. Injury to radial nerve at the wrist, what will it lead to? Now the injury is very distal. It is at the wrist, literally. So now you have to tell what all will occur. Okay. So Mishti and Shraddha both have said that the answer is going to be option B. Sensory loss on dorsum of first left face. Absolutely true. This is the region of the isolated supply where the supply of the radial nerve is isolated supply. Only it supplies, no other nerve supplies this region. Right. So question 11. Last question, a little tricky question. You have to choose the best option. You have to choose the best option. After this question, we'll move to the medial nerve. Absolutely true. How did you do it, Shraddha? Shraddha has done it right. The answer is going to be long head of triceps. So remember that if this is the this was the axilla, here the long head and the medial head were being supplied. And here in the spiral groove, the triceps, the medial and the lateral head were being supplied. The medial head is also supplied in the spiral groove. Wait, wait. Not long head. Yeah. So it is talking about spares. It is talking about spares. So the lateral head will be completely damaged, right? The medial head will also be partially damaged. So what is left? The long head. So the long head of the triceps, that will be spared because it will be supplied in the axilla itself. So the answer is going to be option B, long head of the triceps. We move to the median nerve. Let's move to the median nerve. Finally, so we have ulnar and median nerves left. So far we have covered brachial plexus. Plus how many MCQs? I think 8 MCQs here. Then lesions of the brachial plexus, 7 MCQs. Done radial nerve and 11 MCQs. We've done 26 MCQs and a lot of these important high yield topics. Now we'll be doing median nerve. Yeah, so this class is a little long, but like I told you that if you are listening with full attention, then this class is going to be really useful for you, and it will prepare a lot of topics. It will prepare all your nerve supplies. You won't have to remember separately for which muscle which nerve is supplying. You'll be done with everything, alright? Right up till the hand. So the median nerve, first I want you to remember before we move forward. Median nerve is known as the laborer's nerve. ठीक है, मजदूर की नस, laborers. Now why is it called the laborer's nerve? So what does a laborer commonly have to do? A laborer has to lift a lot of weight, right? And all of the weight has to be lifted with the help of your arm and your forearm. So it is the major nerve of the forearm. It is the major nerve of the forearm, the median nerve. So median nerve, first remember that it is the laborer's nerve and it is the main nerve of the forearm. It will supply all the flexors that are present here in the anterior compartment, because the posterior compartment was anyways being supplied by the radial nerve. So whatever is left mainly will be supplied by the median nerve. There are 1.5 muscles which are supplied by the ulnar nerve. I'll tell you what is 1.5. So that's about the course of the median nerve. First is the root value. First thing that you should know is the root value. Root value is C5 to T1. Root value of the median nerve is C5 to T1. Okay. Second, it moves here. It is a content of the cubital fossa. Remember MBBS or MBBR, whatever you have remembered. Medial most content. M is median nerve. Median nerve. Alright. And S here is superficial branch of radial nerve. So it is formed by two of these branches. First, let's talk about its formation separately. I'll also tell you how to identify this on a cadaver. Okay. So this is your medial nerve. This is, let's say, this is your median nerve. Alright. Median nerve. So remember, median nerve has a median root and it has a lateral root. So it has a medial root and it has a lateral root. Medial root of median nerve and lateral root of median nerve. And this is coming from the medial cord. This is coming from the medial cord, and this is coming from the lateral cord. This is coming from the lateral cord. The median nerve here, it will form this M-shaped structure. It forms this M kind of shaped structure. Alright. That is why it has all the root values. So let's do this with let's make it in a colorful manner. Let's say this was your medial cord. This is your lateral cord. Your medial cord, this is your lateral. Now they give two branches. This is the medial root. This gives the lateral root. Then they join to form the median. That is this typical M-shaped structure. This M-shaped structure is what you have to look for when you look for the median nerve in a cadaveric dissection, right? That is about first about the formation of the median nerve, and it has all these root values. So then it moves forward after the cubital fossa, after the cubital. So it passes through the what? The cubital fossa, not the cubital tunnel. Alright, not cubital tunnel. The ulnar nerve passes through the cubital tunnel. This passes through the cubital fossa. Then it goes between the two heads of pronator teres. It goes deep between the two heads of pronator teres. Alright, it goes deep, and then it gives you two nerves. It divides into two. One is the main continuation. One is the main continuation of the median nerve, which will go through the entire forearm, and even it will go to the hand. And it gives a branch here known as the anterior introitious nerve. So the anterior introitious nerve, you must remember, is a branch of the median nerve, whereas the posterior introitious nerve was a branch of the radial nerve. Okay, that is the first important point here. Okay, then if you talk here, yes, sir, please have a look at your phone. Take a second, guys. Okay. Anyways, let's continue. So the median nerve here, it passes deep through the heads of pronator teres, and then it divides into these two branches. Alright. So then here, this anterior introitious nerve, it gives a branch here which supplies the flexor pollicis longus. It supplies the flexor pollicis longus. Just give me 1 second, guys. So it gives here a branch to the. Let's come back. Sorry, guys. Sorry for the distraction. Cubital fossa passes deep through the pronator teres. Then anterior introitious nerve, it will give a few branches. The main nerve, it will give a few branches, right? So the few branches that are given by the anterior introitious nerve, there are only three. There are only three. So first branch that it gives is to the flexor pollicis longus. It gives a branch to the flexor pollicis longus. Alright. Flexor pollicis longus. Then second branch that it gives is that it supplies the flexor digitorum profundus. Flexor digitorum profundus. That is a deep flexor digitorum. There are two, flexor digitorum profundus and flexor digitorum superficialis. So flexor digitorum profundus, lateral half of flexor digitorum profundus. So if this is this, then the lateral half would mean this outer. Okay, so the index finger, the middle finger up till here, that is the lateral half of flexor digitorum profundus that is being supplied here. Then it ends into a deep muscle here known as the pronator quadratus. So the deep muscles of the forearm are supplied by the anterior introitious nerve, the deep muscles. The superficial muscles are being supplied directly by the continuation of the median nerve. So you will have supplied to the superficial flexors like the flexor digitorum superficialis. Alright. After that, the median nerve, it enters the wrist where it passes deep to the flexor retinaculum. This is the flexor retinaculum. It passes deep to the flexor retinaculum. Over the flexor retinaculum, it gives a branch, a thin branch known as the palmar cutaneous branch. It gives a branch here that is known as the palmar cutaneous branch. Alright. And this deep branch, it goes deep to the flexor retinaculum and it divides into three. It gives a recurrent branch to supply all the thenar muscles except the adductor pollicis. Very important, which is the thenar muscle that is not supplied by the median nerve. The answer is going to be adductor pollicis. Alright, so remember this, except adductor pollicis. And then it gives a branch to the first and the second lumbricals, which are the unipennate lumbricals. And it gives digital cutaneous branches. So what it supplies is, it supplies the lateral 3.5 part of the skin on the front of the hand. So the radial nerve, it was supplying the dorsum of the hand. This is supplying the same skin on the front of the hand. So that is 1, 2, 3, 3.5 digits. Alright. 1, 2, 3, 3.5 digits. And here it will also supply the nail beds. It will also supply the nail beds. Alright. Remember, the nail beds are being supplied by the median nerve. And here you have to remember that this palmar region, it is supplied by the palmar cutaneous branch, and this region is supplied by the digital branches. So if I have to show it here, this pink region is supplied by the palmar cutaneous branch, and this orange region is supplied by the digital cutaneous branches. So why am I stressing on this? Because the palmar cutaneous branch, it is moving over the flexor retinaculum. So if there is pressure on the flexor retinaculum, this palmar cutaneous branch will be spared. This palmar cutaneous branch, it will be spared. So let's revise the median nerve is following. So remember its formation, it's M-shaped formation from the medial and the lateral roots, from the medial and the lateral cords. They will unite to form the main trunk of the median nerve, which will pass deep to the pronator teres. Then it will divide into two to supply separately the superficial flexors and the deep flexors. Alright. The deep muscles in the forearm, on the anterior compartment of the forearm, will be supplied by the anterior interosseous nerve. Okay. Now, what are the deep muscles? The deepest is the pronator quadratus. The deepest is the pronator quadratus. Above that, the flexor digitorum profundus and the flexor pollicis longus. Two muscles supplied by the anterior interosseous nerve. Flexor digitorum profundus, only the lateral half. Flexor digitorum profundus is a hybrid muscle. The medial half is supplied by ulnar nerve. Alright. So then, remaining the flexor, superficial flexors, they are supplied directly by the trunk. Then, when it passes over the flexor retinaculum, it gives a branch that goes over the retinaculum and supplies this palmar cutaneous region. And then there is the main continuation, goes deep to the flexor retinaculum, It gives a recurrent branch to supply these thenar muscles of the thumb. Alright, opponens pollicis, flexor pollicis, and then your adductor pollicis is not supplied, is something that you have to remember. Alright, adductor pollicis we'll talk about. Adductors are supplied by ulnar nerve. So adductor pollicis is not supplied by median nerve, is a very important point. It is supplied by the ulnar nerve. Then it also supplies the unipennate lumbricals, lumbrical 1 and lumbrical 2, supplies a digital branch to supply these digits. Digital branches are coming deep to the flexor retinaculum, and palmar cutaneous branches are going superficial to the flexor retinaculum. Alright. This is essentially the median nerve. You can see its formation, this M-shaped kind of a thing here. It gets formed here. It supplies there's a deep anterior interosseous nerve, which is supplying the flexor digitorum profundus for the first and the second digits, flexor pollicis longus, and pronator quadratus. Pronator teres, flexor carpi radialis, palmaris longus, digitorum superficialis, all these superficial flexors along with the pronator teres, obviously, because it is going between the two heads of the pronator teres. So the pronator teres will obviously be supplied by the median nerve, and then superficial flexors. They will be supplied, then it will enter inside deep to the flexor retinaculum, where before entering it will give a palmar cutaneous branch. Then deep it will give a few branches here. What branches will those be? Abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. But adductor pollicis is supplied by ulnar nerve, not by median nerve, by ulnar nerve. Very important point. Then first and second lumbricals, which are the unipennate lumbricals, they will also be supplied by the median nerve. Then it has sensory supply of the lateral 3.5 digits ventrally plus nail beds. Yeah, again a similar thing. You've been shown various relations also in between. So pronator teres is being pierced here. Remember, moves down, flexor retinaculum, blah blah blah. Everything is being shown in this diagram. I've already explained it schematically. If you want, you can spend 1 minute, 2 minutes looking at this diagram. There's something that you don't understand, you can ask me. Okay, so now this is the point that I was showing you. Look at this. This is the flexor retinaculum. This is the flexor retinaculum. Alright. This is the median nerve. It goes deep to the flexor retinaculum. Alright. It is going, as you can see, it is going deep to the flexor retinaculum. Alright. This is the ulnar nerve. It is going superficial to the flexor retinaculum along with the ulnar artery. ठीक है, so ये पॉइंट यहाँ पे थोड़ा सा अच्छे से दिखा दिया फ्लेक्सर रेटिनाकुलम के साथ रिलेशंस ऑफ मीडियन एंड द अल्नार नर्व. I have to ask some more water, guys. I'm sorry. Actually, ये last night. Yes, we'll also talk about carpal tunnel syndrome, Shraddha, don't worry. First, let's see if you can attempt some MCQs here. So let's talk about this question. Let's first talk about this question. Meanwhile, before I go to the lesions of the median nerve, this is question number 1, question number 2, question number 3. Let's talk about question number 4. Very important question. That is why I'm going to discuss it first. Then I'll go to the clinical part. So Shraddha has written the answer is A. If there's anyone else who thinks the answer is A, please write it in the chat box. Okay. Correct. The answer is going to be adductor pollicis. Adductor pollicis I've already stressed enough that it is supplied by the ulnar nerve, not by the median nerve. It is a muscle of thenar eminence that is not supplied here by the median nerve. It is supplied by the ulnar nerve. Like Shraddha has written, and I think Saini Devnath has also written, there the answer is going to be A. Right? So let's move to the lesions here. So again, like we talked about in the radial nerve, there are high lesions and then there are low lesions. So if there is an injury at the higher level, you have the injury that affects you will be the supracondylar fracture. So if there's a fracture at this level, alright, there's a fracture at this level. You would also have here another syndrome known as the pronator teres syndrome, alright, where the median nerve gets entrapped between the two heads of pronator teres. Or you can have what is known as the Struther's syndrome. Alright. Now what is Struther's syndrome? On the medial side, here you have a ligament, alright, which is kind of very less prominent in humans. It is basically a divorced head of your coracobrachialis. It is the third head of the coracobrachialis. Okay. That is known as Struther's ligament. Not very important, but you need to know that through the Struther's ligament, you have two very important structures passing. One is the nerve, that is the median nerve, and along with that you have some brachial vessels. Alright. So this Struther's syndrome, you have this Struther's ligament and it gets compressed. Alright. So there you will have again median nerve damage at approximately this level. So there are two important things that you should know. If there is any median nerve lesion, opponent's pollicis has to be involved, right? because opponent's pollicis, you don't have a brevis or you don't have a longus, you only have an opponent's pollicis. So opponent's pollicis, this opposition function will always be damaged whenever there is a median nerve injury, and that is an indicator that the median nerve is damaged. And because of that, this thumb will be opposed like this. It will not be able to do like this. It will like be an ape thumb. You remember that apes do not have the capacity of opposition of thumb, right? That is a new thing that was there in humans. So you will have ape thumb like this, and you will have a pointing index finger. All right. So it does not mean that the patient will come to you with a pointing index finger. The test known as the Oshner's clasping test. Now, what is that test? You basically ask the patient to make a fist with both hands. You ask the patient to do like this. All right. You ask the patient to make a fist. But when you ask the patient to make a fist, all right, like this, is not able to flex these two fingers. Why? Because if the median nerve is damaged, flexor digitorum superficialis is gone of all the digits. Alright, all the digits you will not be able to flex because flexor digitorum superficialis is gone. But flexor digitorum profundus of only lateral half is damaged. Medial half is supplied by ulnar nerve. So these digits will still be able to flex, but this index finger mainly will remain unflexed. So there will be a pointing index finger whenever you try to form a fist. So this is Oshner's clasping test, and because of that you will have a pointing index finger, and that is a sign. That is a sign that flexor digitorum profundus is also damaged. That is a sign that flexor digitorum profundus and flexor digitorum superficialis are gone. All right. So this sign is important. Oshner's clasping test. Besides that, you can see that there are other functions that will be gone. You can have a look through, but the two I want you to remember are 1 and 2. Ape thumb deformity will be present in all median nerve lesions, whereas pointing index finger or the Oshner's clasping test will be seen only in the higher level lesions. Alright, and then you know the sensory loss that will be there. Okay. Now, what is the distal lesion? Distal lesion is the carpal tunnel syndrome. Carpal tunnel syndrome. Carpal tunnel, you know, is the under the flexor retinaculum. And what are the various reasons that it can occur? It can be idiopathic, it can be due to myxedema, it can be due to pregnancy, there can be some dislocation of bone, osteoarthritis or rheumatoid arthritis. All of these are reasons for carpal tunnel syndrome. And here, the important thing is that you will still have ape thumb deformity. Why? Because opponent's pollicis will still be damaged. You will have paralysis of these lumbricals, the first and the second lumbricals, you will have paralysis of the thenar muscles. But the good thing will be that you will not have the pointing index finger. Why? Because flexor digitorum superficialis and flexor digitorum profundus have been spared. Flexor digitorum superficialis and flexor digitorum profundus. These two have been spared. Why? Because they are present proximal. They are present proximal to the carpal tunnel. So this you can still be able to clasp these. You will still be able to do this. There will not be a pointing index finger, and that will indicate that the lesion is at the carpal tunnel syndrome. All right. So two things. I will make a flowchart to help you understand this because I know that it can be a little confusing. The first thing you will see is ape thumb deformity. You saw that the patient has ape thumb deformity. So now you know it is a median nerve injury. Now you have to see the site of the lesion. You have to see the site of the lesion. Now again we will see pointing index finger. We will ask the patient to clasp his fists. We will ask him to close his fists. If the answer is yes, the lesion is supra or higher level lesion. The answer is no, he has carpal tunnel syndrome. A very basic question could be carpal tunnel syndrome is due to the injury of which nerve? Please remember median nerve. Okay, ये मत भूल जाना. Right? Again, benediction hand is also a similar thing. It is sometimes very similar to the claw hand by some authors. So when a patient attempts to make a fist, the index and the middle finger, they cannot be flexed. They cannot be flexed. So they remain straight. That is benediction hand. Alright. Pointed index finger हो गया, ape thumb deformity हो गया. And one more thing, that is Tinel sign. Tinel sign. Tinel sign is basically that when there is carpal tunnel syndrome and you compress the nerve by your hand near the flexor retinaculum, you feel there is a radiation of the tingling sensation through your palms and through your fingers. Alright? That is Tinel sign. So let's start with question number one. Let's start with question number one. All is true about carpal tunnel syndrome except. Correct. The answer is going to be C, because wasting and weakness of adductor pollicis will not occur, because adductor pollicis is not supplied by the median nerve. As I already told you, adductor pollicis is supplied by the ulnar nerve. There is no question of wasting and weakness of the adductor. Question number two. Shraddha has also written C. Mishti has also written. Right. So now you know, since the lateral half of the flexor rigitorum profundus is supplied by the median nerve, so the answer here is going to be the median nerve. Very simple. So Mishti has already answered answer for question number two as A. Question number three, carpal tunnel syndrome is caused by all except. Okay, so this is a slightly more difficult question, and if you apply some of your logics, you'll be able to answer this. Okay, but I want you to think a little into this, and then I will give you an explanation. Meanwhile, just give me a minute. Someone's at the door. I'll just Sorry for the delay, guys. Okay, we've just started answering. Shraddha has said C, and Mishti has said that the answer is going to be D, right? So carpal tunnel syndrome, let me tell you guys, the answer is not C, it's not D. The answer is B, Addison's disease. Now why? Because hypothyroidism, as you all know, it causes something known as mixed edema, right? And whenever there will be edema, there are chances that the carpal tunnel will get. So mixed edema, hypothyroidism, you will have carpal tunnel syndrome as a risk factor. Okay, so A nahi hoga answer. Now coming to C, diabetes mellitus. You know diabetes mellitus, nerves get affected. Diabetes mellitus, you have neuropathy, right? So in diabetes mellitus, again carpal tunnel syndrome is a possibility. Amyloidosis, there is a deposition of calcifications, right? And those calcifications can cause compression of the median nerve and the carpal tunnel, right? So amyloidosis is also a risk factor. So answer is going to be B, Addison's disease. Addison's disease, you don't have any direct correlation. Alright. Question number 4, we have already discussed that the median nerve, it supplies all muscles except the adductor pollicis. Question number 5, median nerve injury at the wrist is commonly tested by. Tell me question number 5. The little tough question. So, Mishti has replied. So, question number 5, the answer that has been given by Mishti is C, contraction of opponent's pollicis. Alright. So, why the answer here is not going to be opponent's pollicis is that sometimes the opponent's pollicis is also supplied by the deep branch of the ulnar nerve. Alright, sometimes. So, the answer that I'm going with here is going to be option A. Catch here is that they have written brevis. The catch here is that they have written brevis. Abductor pollicis. If you simply test the abductor pollicis, or if you test the abduction function, right, that can be also be done by abductor pollicis longus. So that is why we stress on opponent's pollicis, because it does not have a longus or a brevis. But here they have tested contraction of the abductor pollicis brevis. So now this brevis word, this becomes very specific. This becomes very specific, and because of that, you see the median nerve injury, you subject the patient to a pen test. So the patient has to lie with his hand flat on a table with his palm facing upward, and he is asked to adduct his thumb to touch the examiner's pen like this, all right? So which is held above it. So this is to test for abductor pollicis brevis, and it is supplied by the median nerve. So this is a little small point here that I wanted to bring out. So don't get confused here. Question number 6. One of the following is supplied by the median nerve. Which of the following is supplied by the median nerve? Okay, Shraddha Sharma has answered. Shraddha, are you giving the answer for question number 5, or are you giving the answer for question number 6? Okay, A, right. Mishti has also given the answer. First and second lumbricals. So remember that lumbricals First and second lumbricals are unipinnate, whereas the third and the fourth lumbricals, they are bipinnate. So bipinnate muscles are supplied by these bipinnate muscles of the upper limb. Bipinnate muscles of the upper limb. These will be supplied by the ulnar nerve. Whereas lumbricals first and second, which are the unipinnate lumbricals, they are supplied by the medial nerve. So yes, that's the correct answer. The rest, all of these, hypothenar, palmar interossei, all the interossei, they are supplied by the ulnar nerve. Okay, Shraddha. Okay, alright. Question number 7. Medial nerve lesion causes paralysis of all of the following except. Medial nerve lesion causes paralysis of all of the following except. So like I told you that this is a very important point that we brought out in question number 7, that adductor pollicis is spared in medial nerve lesions because it is supplied by the ulnar nerve. So let's move directly to question number 8. Let's move to question number 8. Since it is a question of PGI Chandigarh, it is a multi-answer correct. Oh, all of you are giving the answer as adductor pollicis. Yes, adductor pollicis is not supplied by the median nerve. Please don't give the answer as B. Read the question carefully. It is asked that which of the following muscle is supplied by the median nerve, right? So opponent's pollicis, yes, it is supplied by the median nerve. Adductor pollicis not supplied. Lateral half of FDP, yes, supplied. Superficial head of flexor pollicis brevis and deep part of flexor pollicis brevis. Superficial, yes. Deep part is sometimes supplied by the ulnar nerve, but yes, we'll consider it. A, B, C, E, C, D, E. Adductor is by ulnar nerve. So we're moving on to ulnar nerve in a minute. Let's start ulnar nerve at 7 o'clock. Right? So how much have we done? We've done brachial plexus. Covered a lot, guys. We have covered brachial plexus. We have covered herbs and Klumpke's. And we have covered your axillary nerve. Then we've covered your musculocutaneous nerve. We've covered your radial nerve. Then we've covered your median nerve. And now last topic for today, we have ulnar nerve. I know, guys, today's class is getting a little long. In fact, it has already gotten a little long. But now I want you to focus on the last topic, ulnar nerve. Alright? Try to finish it as soon as possible. So this is the schematic diagram for the ulnar nerve. So I've shown you schematic diagrams for each of the three nerves. So please try to go through those schematic diagrams at least if you don't do anything else. You can join my Telegram channel, that is @NEET PG Chetanya, where I will forward all these PDFs from where you can refer to these schematics also. Okay, my Telegram channel, and we also have a discussion group where you can contact me if you plan on taking a Plus subscription. I'll be able to provide you with some cashbacks. So please do use my referral code in case anybody of you takes a plus subscription. Shraddha is asking some doubt. So what do you know about the flexor pollicis brevis? So flexor pollicis brevis, like I already told you, pollicis brevis nerve supply. See, flexor pollicis longus is no doubt supplied by the median nerve. It is supplied no doubt by the median nerve. Flexor pollicis brevis. Okay, let's do this. Flexor pollicis brevis. It has two parts. First of all, it is a thenar muscle. So, in a general sense, thenar muscles are supplied by the median nerve except adductor pollicis, right? So, flexor pollicis should also be supplied by flexor pollicis brevis should be supplied by the median nerve. It has a superficial part and it has a deep part. Okay, so both of these heads they are mostly supplied by the recurrent branch. It's shown you a recurrent branch of the median nerve. Sometimes the deep part is supplied by the deep branch of the ulnar nerve. Sometimes, in that case, flexor pollicis brevis becomes a hybrid muscle. I've stressed on this point later. Sometimes the deep part is supplied by the deep branch of the ulnar nerve. So you can or cannot consider this. That is up to you. All right. Let's start with the ulnar nerve now. It's too late. Anyways, ulnar nerve is relatively smaller. You have lesser number of lesions. Yeah. So here, the important point in ulnar nerve will be ulnar paradox. So let's start from here. So remember that the radial nerve, it was passing anterior to the lateral epicondyle. Now you have the ulnar nerve, it passes deep to the medial epicondyle. It passes deep, it passes posteriorly to the medial epicondyle. First very important point. Then the radial nerve, it pierces the supinator muscle, whereas the ulnar nerve, it passes through the two heads of the flexor carpi ulnaris in this is known as the cubital tunnel. This is known as the cubital tunnel. So there are two syndromes. One is carpal tunnel syndrome. The other is cubital tunnel syndrome. Carpal, please don't get confused between these two. The MCQ would be which of the following nerves is involved in cubital tunnel syndrome. Please don't attempt it as median nerve. Alright. Cubital tunnel read separately. Carpal tunnel read separately. Carpal tunnel syndrome, median nerve. Cubital tunnel syndrome, ulnar nerve. Alright. Very important. Yes, it supplies the flexor pollicis longus. The anterior interosseous nerve will supply the flexor pollicis longus. You're absolutely correct. And get your question per se, Shraddha. ठीक है तो ये medial epicondyle है flexor carpi ulnaris के through pass कर रही है in cubital tunnel. Then it supplies it is mainly a muscle of the hand. It does not care much about the forearm. Alright, it is mainly a muscle of the hand. That is why I told you that laborer's nerve is median nerve. Laborer's nerve is median nerve and ulnar nerve is known by another name. Ulnar nerve is known by another name and that other name is a very beautiful name, that is musician's nerve. That is musician's nerve. So if there is anything related to the ulnar nerve, these intrinsic muscles of the hand, they are affected, and musician's nerve. So musician or like this, any of these fine movements of the hands, mainly hand muscles are innervated by the ulnar. That is why ulnar nerve is the musician's nerve. So it supplies only 1.5 muscle. It supplies only 1.5 muscle in the forearm. That first muscle is flexor carpi ulnaris because it passes between its two heads. So it will obviously innervate the flexor carpi ulnaris. It also innervates the medial half of the flexor digitorum profundus. So now you know that flexor digitorum profundus is a hybrid muscle. Why? Why is it a hybrid muscle? Because it is having dual nerve supply. Medial half is by ulnar nerve and lateral half is by median nerve. Okay. Then it passes superficial to the flexor retinaculum. This is the flexor retinaculum. So it passes superficial, whereas the median nerve was going deep to the flexor retinaculum. So 2 points of differences. What is the difference with the radial nerve? Radial nerve passes over the epicondyle. This passes deep to the epicondyle. The median nerve passes deep to the retinaculum, whereas the ulnar nerve passes superficial to the retinaculum, and then it goes into this sort of a canal, which is known as the Guyon's canal, or the Piscio-hamate tunnel. It is also known as the Piscio-hamate tunnel. So it is between the pisiform bone and the hook of the hamate. Sorry, not the hook of the hamate, between the pisiform bone and the hamate bone. So this is the Piscio-hamate tunnel or the Guyon's canal. Alright, and through this the ulnar nerve passes. It divides into a superficial branch and in a deep branch. Alright, the superficial branch passes and supplies only one muscle, that is palmaris brevis. Okay, so क्या हुआ? The ulnar nerve, it came out, passed over the flexor retinaculum, went into a canal here known as the Guyon's canal, and divided into a superficial branch and a deep branch. So the superficial branch supplied only one muscle here known as the palmaris brevis. Not very important as a muscle, but very important as an MCQ. Alright. And then there is a deep branch which continues along with the palmar arch, the arterial palmar arch, right? And then here you will be having some nerve supply, right? So the deep branch, first it supplies all the hypothenar muscles. Now what are the hypothenar muscles? Your digiti minimi, flexor digiti minimi, abductor digiti minimi, opponens digiti minimi. All of these muscles, they are supplied by the deep branch. Then it supplies all the interossei, the palmar interossei, the dorsal interossei. It will be supplying all the interossei. Then it gives a nerve supply to third and fourth lumbricals, which are the bipinnate lumbricals, right? The unipinnate lumbricals are supplied by the median nerve. The bipinnate lumbricals are supplied by the ulnar nerve. Alright? Okay, so Vimala is a NEET UG aspirant, but she's here for my teaching. I'm glad you're a fan of my teachings. Yeah, thank you. So then finally, there was one muscle that is now left for the ulnar nerve to supply, which we talked so much during the median nerve, and that is the adductor pollicis. So ultimately it will say कि चलो अब सब हो गया, अब जाके adductor pollicis को supply दे आते हैं. So adductor pollicis is the graveyard of the ulnar nerve. Why? Because it is the last muscle, आखिरी station, terminal station जो हो रहा है supply during the course of the ulnar nerve. So graveyard of ulnar nerve is adductor pollicis. So now I hope you're clear with the course. Comes behind the medial epicondyle, passes forward, goes between the heads of the flexor carpi and larynx, also supplies it, then moves, supplies the medial half of flexor digital profundus, therefore supplying 1.5 muscle in the forearm, moving superficial to the flexor retinaculum, passing through the Guyon's canal, also known as the Piscio-hamate tunnel, giving a superficial branch which supplies only the palmaris brevis, giving a deep branch which supplies a lot of muscles, including all hypothenar muscles, all interossei, all the bipinnate lumbricals, that is the third and the fourth lumbricals, and finally supplying a thenar muscle known as the adductor pollicis, which is the graveyard of the ulnar nerve. Okay. Now this is the point that we were talking about earlier. Sometimes the deep branch of the ulnar nerve will supply the deep head of the flexor pollicis brevis. So flexor pollicis brevis is वैसे otherwise supplied by the median nerve, but it has two heads, superficial and deep. Superficial is always supplied by the median nerve. Deep head may be supplied by the deep branch of the ulnar nerve, and in that case, flexor pollicis brevis also becomes a hybrid muscle, right? So let's finally talk about the sensory distribution of the ulnar nerve. So what is left? This 3.5 was done, so only 1.5 is left. So 1.5 anteriorly and 1.5 posteriorly will be supplied by the ulnar nerve, including the nail beds, everything. ठीक है? तो sensory distribution of hand clear हो गई? If I draw, will you be able to tell me which part of the hand is supplied by what? So this is the ventral part, This is the dorsum of the hand. The dorsum, you know that 3.5 will be supplied by radial nerve. Okay, then this upper part will be supplied by medial nerve, nail beds. Then this whole part will be supplied by ulnar nerve. Here also, then this part is supplied by ulnar nerve. This entire part is supplied by medial nerve. Alright, you can also Google a diagram. You'll find a good diagram of the sensory innervation of the hand. Alright, now we'll be talking about, now last thing that we have to talk about is the lesions of the ulnar nerve. Last thing we have to talk about is the lesions of the ulnar nerve. And what is very important in the lesions of the ulnar nerve is ulnar paradox. Can anybody tell me what exactly is the ulnar paradox? क्यों कहते हैं उसको ulnar paradox? I'll tell you two reasons why it is the ulnar paradox. You'll be only able to tell me one. I challenge you to tell me two reasons why it is called the ulnar paradox. What is the exact paradox here? Okay. Anyways, let's move ahead. First, so here basically there are two things. One is the high lesion, the other is the low lesion. So again, let's call this the proximal lesion, and let's call this the distal lesion. Okay. So proximal lesion, you will, where can you have a lesion in the, you can have the ulnar nerve passes through the cubital tunnel, like I told you. So cubital tunnel syndrome is one of the main lesions here. Then it can get compressed between the two heads of the flexor carpi ulnaris. Like there was pronator TD syndrome there. Here you can have compression between the two heads of the flexor carpi ulnaris. Alright. Then there can be a deformity here of the elbow, tardi ulnar nerve palsy, and that will also cause a deformity here. Or you can have a fracture here, right? So all of this will be a high level lesion where you will have claw hand deformity. You have claw hand, something like this. This is claw hand, okay? So claw hand deformity हो जाती है, and you will have hypothenar and interosseous wasting, right? You will have loss of abduction and adduction of fingers. So card test, that is known as the Froment sign. Alright, you will not be able to adduct the thumb. You have loss of adduction, right? So there is Froment sign positive, that is adduction of thumb. Then weakness of the wrist flexion, hand deviates to radial side upon flexion. Alright. Now this is again not very important, but again in the wrist you will have the similar things. You will have claw hand deformity, you will have hypothenar wasting, loss of these functions, and the more important thing is that the claw hand deformity now is more pronounced. Claw hand deformity is more pronounced. Alright. One more difference is that here you have a sparing of the dorsal cutaneous branch. Yeah, but let's not go into that. So where all can you have a low level lesion of the ulnar nerve? One can be your nas kaatne wala, that is wrist laceration or slashing. The second is a Guyon's canal syndrome, where you have damage in the pisciohamate tunnel, right? So remember there was a Guyon's canal through which it was passing. So if there is a constriction or there is a compression of that canal, then also you can have ulnar nerve palsy, right? So now important thing here is the ulnar paradox. Ulnar paradox. So remember here we said one thing that the claw hand is more pronounced when you talk about distal lesions, when you talk about more distal lesions. So now why is that happening? What is basically claw hand? Claw hand is basically that your fingers are getting hyper flexed here and they are getting extended here. तो बहुत ज़्यादा इधर flex हो जा रही है. क्यों? क्योंकि see the what is happening here is these muscles that are being supplied. So since you know it supplies most of the muscles of the hand, because of that, this kind of a appearance is coming. Alright. Now this is the medial half. This is the medial half. So flexor digitorum profundus ka medial half. Remind me, flexor digitorum profundus, medial half is also supplied by the ulnar nerve. So to flex these, you need flexor digitorum profundus. To flex these, you need flexor digitorum profundus. Now if flexor digitorum profundus is working, you will have a stronger claw hand or a weaker claw hand. You will have a more pronounced claw hand or a less pronounced claw hand. If flexor digitorum profundus is working. So see, these fingers are like this. If you have to have a claw hand, it has to be like this, right? For that, there has to be flexion here. For that flexion, you need flexor digitorum profundus. If flexor digitorum profundus is working, claw hand will be more prominent. And if flexor digitorum profundus is paired, it will be yeah. So it is, if it is working, it will be more prominent. And on the other hand, if it is damaged, the flexor function of flexor digitorum profundus will not be occurring. So claw hand will relatively be mild, right? So that is why here what happens, if the lesion is at this level, flexor digitorum profundus is also not working. So the flexion is not very much. So the claw hand is not very prominent. But if the lesion is here at the Guyon's canal, the flexor digitorum profundus function is not lost. So it flexes even more, causing a more pronounced claw hand. Alright. So here you can see that is the paradox essentially. That if you looked at the other nerves, as the lesions became more distal, there was some symptoms which were lesser. There were symptoms became lesser, alright, and the severity became lesser. But here, if you come more distally, if the lesion is present more distally, the symptoms or the signs are more severe, alright. So claw hand is more pronounced in the low injury, since flexor digitorum profundus is not paralyzed and there is marked flexion of the interphalangeal joints. Sensation is spared because the dorsal branch is given off proximal to the wrist joint. ठीक है, ये बात अभी यहाँ पे हमने डिस्कस नहीं करनी है ulnar paradox में. This is the first point of the ulnar paradox. First point is related that if lesion is more distal, it should have been less severe, but it is more severe. So that is the first point of the ulnar paradox. The second point is, if there is an injury that is a high injury, so if an injury has occurred here, when it starts to re-innervate, you will have re-innervation occurs from proximal to distal, right? Re-innervation will occur from proximal to distal. So when flexor digitorum profundus is re-innervated, the deformity gets worse and then the patient recovers. Get it? What happened? There was an injury of the elbow here, right? Ulnar nerve got damaged. Alright, you had claw hand. Then it started to get re-innervated. It started to heal. So when it was healing from top to bottom, first the flexor digitorum profundus got re-innervated. When it got re-innervated, this flexion became stronger. So the symptoms became worsened. The claw hand was more severe. Since the claw hand now became more severe, the patient will first be in a more severe position and then he will suddenly recover. So what will happen? First you will have mild claw hand, then it will become severe and then it will completely disappear. That is a paradox, that while recovery it gets worse. During recovery it gets worse. Why? Because flexor digitorum profundus gets innervated. Please tell me you have understood this point. Okay. देखो, अगर किसी को चोट लगे और वो धीरे धीरे हील हो तो क्या होना चाहिए? दर्द को आराम मिलना चाहिए. The problem should start to get a little resolved. But here the opposite happens. The problem first worsens and then resolves. So that is why this is another point why there is an ulnar paradox. So there are two things. One is related to distal proximal. Second is related to healing and re-innervation. Second is related to healing and re-innervation. So there are 2 points here that you should stress upon. Okay, this is related to the ulnar paradox. You can read this, that in the high lesions, the ulnar half of flexor digitorum profundus is paralyzed. So the fingers are less clawed. Otherwise, everything is the same almost. Okay. So now question number 1. All are true about the ulnar nerve except. All are true about the ulnar nerve except. So before we move to the MCQs, can somebody please tell me that they have understood both aspects of the ulnar paradox? Can you please write a yes or no if you have understood? Or they have not understood. In any case, let's move on to question number 1. All are true about the ulnar nerve except. All the statements are true about the ulnar nerve except. Okay, thank you, Shraddha. Thank you for telling me that you liked the explanation. Can anybody answer this question? Okay. Supplies flexor digitorum superficialis. Yes, this is false. It does not supply the flexor digitorum superficialis. Neither does it pass through the flexor digitorum superficialis. So B and C both are false. It supplies the flexor carpi ulnaris. It passes behind the medial epicondyli, and its root value is C8. It also has C7, although, but it is still true. C8, T1 are there. So B and C are definitely wrong. They are definitely alright. That is about question number 1. B and C are incorrect statements. Question number 2. In the arm, the ulnar nerve gives a muscular branch to which muscle? Okay. So Mishti has said the answer is D. Ulnar nerve, it gives a muscular branch to which of the muscles? Flexor carpi ulnaris, flexor digitorum profundus, both, none. Even Vinita has given the correct answer. The answer is D, none. How do you know that the answer is none? The catch here is that it is written arm. This had this been forearm, the answer could have been both. Had this been forearm, the answer would have been both, because it also gives a branch to flexor carpi ulnaris and it also supplies the medial half of flexor digitorum profundus. But in the arm, the ulnar nerve does not have any nerve supply, so you don't have to think anything. The answer is going to be none. Question number 3. False regarding the ulnar nerve. Absolutely right, Mr. Okay. So false regarding the ulnar nerve. Does it pass between the supinator heads? No. It passes between the flexor carpi ulnaris. It passes between the two heads of the flexor carpi ulnaris. Alright, that is the first thing. Okay, so D is incorrect, that is true. Root value C7, C8, T1, that is true. It has no branch in the arm, that is also true. It lies superficial to the flexor digitorum profundus and the flexor retinaculum, this is also true. C7 fibers arise from the lateral cord. Now you have to tell me about option A. C7 fibers arise from the lateral cord. What was the lateral cord formed of? The ulnar nerve. Now you are saying the answer is D. Fine. That's the false statement. Question number 4. Froment test. Froment test. I just told you that what does the Froment test check? Which muscle does the Froment test check? Okay, so you're right. The answer is adductor pollicis. The Froment test is used to test the adductor pollicis. Question number 5. What does the ulnar paradox imply? Question number 5. What does the ulnar paradox imply? Okay, right. So ulnar paradox means a high level injury and a less severe claw hand. This is absolutely true. You all can probably relate to this by this is called the ulnar paradox. Yeah. Sorry guys. All. Yeah, so simple ulnar paradox means that if the injury is at a higher level, you have a less severe claw hand, and if it is at a lower level, you have a more severe claw hand. Then question number 6: ulnar injury in the arm leads to all except. Ulnar injury in the arm, it will lead to all except. there's an ulnar injury, then will you have sensory loss of the medial 1/3 of the hand? Sensory loss of the medial 1/3 of the hand. So yeah, you will have sensory loss of the medial 1/3 of the hand. Will you have weakness of the hypothalamic muscles? You will have that, yes. Will you have claw hand? Classical sign of an ulnar nerve injury. So answer will be option D, adduction of the thumb. There will not be adduction of the thumb since there is damage to the adductor pollicis. There will be damage to the adductor pollicis. So there is loss of adduction of the thumb would have been correct. Okay. So question number 7. The superficial branch of the ulnar nerve, what muscle does it supply? So I told you that this question is important from an MCQ point of view. This muscle is important from an MCQ point of view. Guys, do you guys also want me to quickly summarize the entire class? If you want that, do let me know, because I guess this must be the second last question. If you want me to summarize the entire class, just let me know and I will tell you all the basics at least in 10 minutes more. Because this became a long class, I know that you might have lost attention somewhere, you might not have paid attention to a few points. Okay. Yeah, absolutely right. Mishti has written 7A Palmaris brevis. 7A Palmaris brevis. Okay. No, not opponens pollicis. Only a single branch is supplied by the superficial branch of the ulnar nerve, that is going to be Palmaris brevis. Question number 8, last question probably. Since it is a PGI Chandigarh question, it is a multi-answer correct. Please remember. True about the Guyans Canal. True about Guyans. Last question. And after this, please tell me if you want me to summarize or you just want me to end the class. I am fine either way. Okay. Priyanka is saying a summary would be great. I'll just do that. Because we've covered literally too much today. We've covered so much that if you watch this class, I don't think you need to do anything related to nerves in upper limb except this. In nerves सब समझ आ गई, आर्टरी सब समझ आ गई, तो अपर लिम्ब में रह ही क्या गया, थोड़ी मसल्स वसल्स रह गई, उनका ओरिएंटेशन एक बार एटलस से देखना, सारी मसल्स का ओरिएंटेशन बन जाएगा. अपर लिम्ब यही है और तो कुछ है ही नहीं. Okay, right. So Guy's canal, it conveys the ulnar nerve, that's true. So it is the piscio-hamate tunnel. Remember I told you it's pisiform bone and hamate bone. It lies at the wrist, alright, not at the medial epicondyle, not between two heads of pronator teres, not between the two heads of flexor carpi ulnaris. It is between two bones. So A and B both are correct. Conveys the ulnar nerve and it lies at the wrist. Okay. So two statements are correct. So now, guys, I'm done with the more or less with the part. Now my role as a here is to summarize everything for you. So to summarize, we'll have to go to the first slide. तो काफी कवर किया आज हमने. Start from our first teachings. So first, since अब ये slide खुली गई है, so I was telling people to take the iconic subscription. If you take it, you use my referral code, you contact me, so that you get some additional cashback from my end. All right, ATM कर देंगे, मस्त. Okay. First, let me talk about what is the stuff that we started to talk about. Okay, will do, Shraddha, will do. See, the sequence that we did was brachial plexus, and we did Erb's palsy, Rumpke's palsy, then we did axillary nerve, then we did musculocutaneous nerve. क्या मतलब अगर किसी ने वीडियो में बेसिकली स्किप करके कुछ स्पेसिफिक देखना हो, so for that I am telling you this. We did radial nerve, then I did median nerve, and I did ulnar nerve, right? And after every topic, so here we did around 8 MCQs, here we did around 7 MCQs, then we did around I think 11 MCQs of the radial nerve, फिर 8 MCQs इधर भी करें, 26 34 around 45 MCQs कर लिया, ठीक है, nerves. So this was the entire thing that we did today. Alright. So now if I have to start, I'll start with the brachial plexus. Quickly, let's go through each of the key points. Alright. So brachial plexus, you all know, you will be supplying the entire part here. So roots, trunks, divisions, cords, branches. So what you have to remember? You have to remember all the branches. How many branches are there? There are 17 branches. So two direct branches from the roots, which are those dorsal scapular nerve and suprascapular nerve. Dorsal scapular nerve and the long thoracic nerve. Two direct branches from the trunks are the suprascapular nerve and the nerve to subclavius. Then you have three cords, lateral, posterior, medial. You have to remember each of their branches. You have to know how those cords are being formed. So direct branches, dorsal scapular, it supplies three muscles, the retractors of the scapula, levator scapulae, and the two rhomboids, right? And long thoracic nerve will supply the serratus anterior. Upper trunk branches, suprascapular nerve and nerve to subclavius. Nerve to subclavius will also sometimes give the accessory phrenic nerve. Suprascapular nerve supplies two muscles. It is suprascapular, but it supplies both supraspinatus and infraspinatus, right? And for cords, I already told you these mnemonics. So for lateral, you have L, M, L. Please see in the slides what is L, what is M, what is L. Posterior, I told you that you have these mnemonics, lunar or ulnar, whichever you want to use. And there was also an option to use a mnemonic that is stars, where this was upper subscapular, lower subscapular, thoracodorsal, axillary, and radial. So these nerves were part of stars. Then after that, you had the medial nerve, that is M for U, where you had 4 M's and 1 U, and that U was ulnar. Remember, ulnar is not from posterior chord, even though the mnemonic is ulnar there, right? Then these are the things, so you can just have a look. L, M, L, screenshot lena hai to. Done. Next, ulnar में U here, U, L, N, A, R, ठीक है, तो इसको हम स्टार्स वाले फॉर्म में लिखा था हमने. फिर उसके बाद M फॉर U, फिर 4 M वाले, एक ये U, तो टोटल हो गई ना 17 branches. Done. Right, after that we had done these questions, all of these questions. Through the questions quickly. Then we talked about the injuries, where I told you that the Erb's palsy, all the points that you have to remember were the root values, that is C5 and C6. Because C5 and C6 are involved, axillary nerve will be there, and because of that deltoid will be injured. Since deltoid will be injured, there will be, because of injury of deltoid, you will have adduction and medial rotation at shoulder joint. And because biceps and brachialis are gone, you will have extension at the elbow joint. And biceps is also a supinator, so you will have pronation at the radioulnar joint. Okay, so that is Erb's palsy, which is also known as the policeman tip hand deformity, or the porter's tip hand, or the waiter's tip hand. Okay, then we moved on to the Klumpke's paralysis, which is the lower brachial trunk palsy, where the main sign is the claw hand deformity along with Horner syndrome because of damage to the T1 sympathetic fibers. ठीक है, Klumpke paralysis. फिर ये paralysis के questions आ गए थे थोड़े बहुत. Then we move to the axillary nerve. Axillary nerve, I told you to remember the root value, to remember that it supplies deltoid, it supplies the teres minor, very important. It has a pseudoganglion and it has some cutaneous supply over the skin over the deltoid. Okay, that is about the axillary nerve. Musculocutaneous, remember the mnemonic here is BBC. The muscles that it supplies, the mnemonic I use is BBC. That is biceps, brachialis, and coracobrachialis. These are the three muscles that it supplies. And it continues as the lateral cutaneous nerve of the forearm anteriorly. ठीक है, आगे को. Then radial nerve में हमने क्या क्या बात करी? We talked about its course. Axilla में it gives a few branches, then it moves to the spiral groove, gives branches to the triceps again, gives branches to the brachioradialis and extensor carpi radialis longus, because of which if the lesion is distal to this part, there will not be a wrist drop, because extensor carpi radialis longus, it will compensate. Then it moves anterior to the lateral epicondyle, divides into the superficial and the deep branches. Deep branch passes deep to supinator and forms the posterior interosseous nerve. Superficial branch, it has some cutaneous supply, and then posterior interosseous nerve will supply all the extensors here. Alright, because of which you will also have, because extensor digitorum gets damaged, that is why you have finger drop. Okay. ठीक है. अब वेरियस लेवल्स ऑफ लीजन्स देखे थे इसमें. एक्सिलरी लीजन, क्रच पैल्सी, रेडियल ग्रूव लीजन, हनीमून पैल्सी, लेटरल एपिकॉन्डाइलर फ्रैक्चर एंड डिस्टल फ्रैक्चर विल बी पोस्टीरियर इंट्रोशियस नर्व डैमेज. ठीक है. इसमें क्या क्या सिम्टम्स आएंगे वो इस स्लाइड में समराइज्ड है. इसमें रिस्ट ड्रॉप, फिंगर ड्रॉप और फ्लेक्स्ड एल्बो. इसमें ट्राइसेप्स पार्टली इन्वॉल्व है तो एल्बो फ्लेक्स नहीं होगी, और इसमें रिस्ट ड्रॉप नहीं होगा, सिर्फ फिंगर ड्रॉप होगा. ठीक है. तो कहाँ पे रिस्ट ड्रॉप, कहाँ पे फिंगर ड्रॉप, वो सब समझाया था. एंड दिस इज अ समराइजेशन ऑफ दैट टायर एक्सप्लेनेशन. ठीक है. उसके बाद इसके हमने आई थिंक 11 क्वेश्चंस करे थे. दिस इज अ कॉकअप स्प्लिंट. रेडियल नर्व हो गया. फिर मीडियन नर्व पे आ गए थे. मीडियन नर्व का कोर्स समझाया था. देखो, C5 to T1 it starts here. I told you about its M-shaped formation, right? It receives the root from the medial and the lateral cords. Then it passes between the heads of the pronator teres, and it gives the anterior introitious nerve, which will supply the deep muscle, the flexor pollicis longus, flexor digitorum profundus lateral half, and pronator quadratus. In the main nerve will supply the superficial flexors, including the flexor digitorum superficialis. The main nerve gives a branch known as the palmar cutaneous branch, which passes superficial to the flexor retinaculum. Deep to it, you will have the muscle that is going, you will have the branch that is going, which will supply lumbrical number 1 and lumbrical number 2. It will give a recurrent branch to supply all the thenar muscles except adductor pollicis. Very important point that adductor pollicis is not supplied here. Then it also gives some digital cutaneous branches, and it will supply the, again, it will supply the lateral 3.5 of the. ठीक है. ये रही बात मीडियन नर्व की. ये रहा मीडियन नर्व का कोर्स, कौन सी मसल सप्लाई करेगा. एक बार ये डायग्राम्स देख लेना अच्छे से. बात बता दी थी. अच्छा, अब इसकी इंजरी में हायर लेवल की इंजरी होगी तो उसमें इंपॉर्टेंट वाज हियर दैट यू विल हैव अ पॉइंटिंग इंडेक्स फिंगर इन द ऑस्टर्स क्लासिक टेक्स्ट. In both cases, in higher and lower injuries, you will have ape thumb deformity. In higher injury, you will also have pointing index finger, whereas in lower injury, you will not have a pointing index finger. Right? तो दो चीजें याद रखना. बेनेडिक्शन हैंड इज related to the median nerve and Tinel sign is related to the median nerve. Okay, then we discussed some questions here. 5, 6, 8 questions here. Then we move to the ulnar nerve. Ulnar nerve, I told you that it passes behind the medial epicondyle, passes between the two heads of the flexor carpi and ulnaris, supplies medial half of flexor digitorum profundus, moves in the Guyon's canal, gives a superficial branch that supplies the palmaris brevis, gives a deep branch which supplies all the hypothenar muscles, all the introiti, the third and the fourth lumbricals, and ends finally in the adductor pollicis, which is the graveyard of the ulnar nerve. Okay. Ulnar paradox, already told you two reasons why it is called the ulnar paradox. First, that during its healing, the patient first gets worse and then the patient recovers. Second thing, that the deformity is more pronounced when the injury is at a lower level rather than at a higher level. Okay. That is also about ulnar paradox. Then we did, I think, a few questions related to the ulnar nerve. 1, 2, 3, 4, 5, 6, 7, 8 questions here. So that's about this, guys. So finally, I want to ask you to please use my referral code, that is Chetanya 10, whenever you try to get a plus subscription. Okay. So somebody contacted me and they took a subscription for some of their family members, right? Their brother or their sister, and then they used my referral code. They had taken a subscription, iconic subscription for IIT JEE, and I gave them a cashback from my side, right? 4,000 rupees. So if you have to take any plus subscription, do use my plus referral code Chetanya 10. I promise you I will give you some sort of incentive from my end. You can join my Telegram channel where I'll be putting the notes for this class. Thank you, Priyanka. I'm glad you liked it. And do don't forget to subscribe to this channel, that is Let's Crack NEET PG, Unacademy's YouTube channel for the NEET PG division, where I'm taking free classes. And download the Unacademy learning app. You can also hit the bell icon for notifications so you keep getting updated as to when I'm live here. And so yeah, that's the main thing. I just wanted to stress on the referral code again. You'll get a 10% discount, plus you'll get 10% credits, and plus you'll get some incentive from my end, right? So that's about it. Somebody texted me about the pricing on Telegram. So I'll just show that slide once again. This is for the Unacademy Plus, and this is for Unacademy Iconic. And like I told you, for NEET PG Unacademy Iconic not only gives you benefits of Unacademy Plus, but it also gives you all the benefits of Prep Ladder. Yeah. So the plan here that you should take if you are in the second year, you're in the third year, if you are in the final year. Final year में हो तो एक year का plan ले लो, obviously, and third year में हो तो 2 year plan ले लो, second year में हो तो 3 year plan का ही फायदा है because next examination हो जाएगा तुमसे. हाँ. तो whatever suits you best, and I would recommend कि यार Unacademy Plus सब्सक्रिप्शन लेने की बजाय ना थोड़ा एक्स्ट्रा पैसा डालो और आइकॉनिक सब्सक्रिप्शन ले लो जिसमें साथ में प्रेप लैडर भी मिल जाए. ठीक है, तो तुम्हें उसमें कोई रिग्रेट नहीं होगा. और yeah, चलो, okay guys, that's about it. I'll be just ending the stream now. Thank you for watching. If there's any doubts, you can ask me. I'll be ending the stream in a minute. 2 minutes are over. Ending the stream now.